cervical lymphadenopathy. Yeah, 70-year-old female presents with progressive cervical lymphadenopathy. There are night sweats, recurrent infections. On examination, hepatosplenomegaly is noted. Peripheral blood smear is given. What is your diagnosis? So I hope it was easy for all of you to diagnose. If I can just tell you two important one-liners, please answer me. We are not sure will it be available in YouTube, but we'll try. Okay. Okay, we'll try to upload it over there as well. Please tell me the answer for the most common type of leukemia in adults. The most common type of leukemia in adults. So definitely here we are talking about leukemias, which are WBC malignancies. So the basic difference to be discussed about leukemia and lymphomas. What is the basic difference? So please remember 2 or 3 important things you need to differentiate. First, leukemia, they arise from the bone marrow. Okay, leukemia, they always arise from the bone marrow, whereas lymphomas are the ones, they can arise from any lymphoid tissue in the body. Okay, lymphomas can arise from any lymphoid tissue in the body. Second, leukemias never form a mass. Leukemias will never form a mass, whereas lymphomas, they always form a mass. Okay, most of the times, lymphomas will form a mass as such. Okay, please remember. Leukemias are usually transmitted or spread by hematogenous route. Okay, leukemias usually spread by hematogenous route, whereas lymphomas, they can spread by hematogenous as well as lymphatic route. Lymphomas can spread by hematogenous as well as lymphatic route. No issues with this. So that was the basic difference. So if I talk about leukemia, what is the most common type of leukemia in adults? So please remember, guys, now according to the recent ones, it is CLL to be answered. Okay, please remember, according to the recent once, it is CLL, that is chronic lymphocytic leukemia. Okay, so chronic lymphocytic leukemia is the most common type of leukemia in adults. It is not CML. Okay, and whereas if I ask you which is the most common type of leukemia in children, the most common type of leukemia in children would be anybody. Most common type of leukemia in children would be the most common type of leukemia in children would be. Very good. It is ALL, that is acute lymphoblastic leukemia. So both of the leukemias are from the lymphoid lineage. For adults, it is chronic lymphocytic leukemia. For children, usually it is the acute lymphoblastic leukemia or the ALL variety, right? So now, I hope all of you are quite aware that chronic leukemias and acute leukemias are usually differentiated based on 2 conditions. First is usually the course of onset of symptoms. Okay, the onset of symptoms would be very rapid in acute leukemia, whereas it would be gradual or it would be time taking in chronic leukemia. First thing. Second, based on the bone marrow biopsy or bone marrow aspiration, in bone marrow biopsy in acute lymphoblast, in acute leukemias, usually the blast cells would be more than 20%. In both the acute leukemias, on bone marrow, the bone marrow biopsy, usually the blast cell would be more than 20%, whereas in chronic conditions, they would be less than 20%. Usually they would be less than 20%. I'll discuss about the blast crisis one. Okay, don't worry about that. So now here the patient is having progressive cervical lymphadenopathy along with TB-like features. And what are TB-like features? Usually there would be night sweats in the patient. Okay, there would be evening rising fever in the patient. There can be anorexia or loss of appetite, and that will cause weight loss in the patient. Okay, so all of these are constitutional symptoms of TB. So such features would be seen. There would be features of recurrent infections in this patient like pneumonia, or there is also damage. Okay, there is also destruction of the platelets causing thrombocytopenia leading to petechiae or purpura, or there can be even damage to the RBCs causing autoimmune hemolytic anemia in this patient. So all of these patients, all of these features usually seen in a 60 to 70-year-old person, 60 to 70-year-old person, that is in the 6th or the 7th decade of life. The more commoner cause would be chronic lymphocytic leukemia. The more commoner cause would be chronic lymphocytic leukemia, right? More and more RBCs and platelets and WBCs are being destroyed. Therefore, there would be hepatosplenomegaly in the patient. Therefore, there is a hepatosplenomegaly in the patient. On peripheral blood smear, if I see, okay, so the diagnosis over here, as I told you, it is chronic lymphocytic leukemia, which is more common in 60 to 70 years of age group. All of these symptoms would be seen. Sorry. Now on peripheral blood smear, if I can just zoom it in for you, here you can see that these type of lymphocytes are seen, right? Very good, all of you. So these type of lymphocytes are seen. So chronic lymphocytic leukemia will arise from the lymphocytes, and mainly those are the B lymphocytes. So there would be immune incompetent B cells which are formed. Immune incompetent, why? Because they would not have the ability to fight infection. Therefore, these are immune incompetent B cells, which will proliferate extensively. They will divide and redivide and redivide. Okay, so extensive division is seen. And when these B lymphocytes are found, which are fragile and immune incompetent, okay, whenever we will prepare a glass slide, they would be broken down. And such type of a picture is seen on a peripheral blood smear. And what are these cells called as? They are characteristically called as the smudge cells. These are called as the smudge cells. Yes, also termed as parachute cells or the basket cells. Also termed as the parachute cells or the basket cells. And this is important. Please remember, guys. ये याद रखना important है, because this is how you differentiate leukemias usually. Okay. On peripheral blood smear, if you are seeing smudge cells, parachute cells or basket cells, that is more likely a feature of chronic lymphocytic leukemia in the patient. Okay, chronic lymphocytic leukemia, right? And as these immune incompetent B cells are formed, though the B cell number is increased, but they are not able to fight infection, and therefore the patient is having recurrent infections. Okay, like pneumonia can be there, herpes infections can be there, all of that. Now, if I talk about the workup of this patient, definitely on lab investigations on a CBC, anemia would be there, HB would be low in this patient, there would be thrombocytopenia in this patient. Okay, WBCs usually would be elevated somewhat. Okay, WBCs can either be normal, they can be elevated. Okay, usually WBCs are grossly elevated in acute leukemias. WBCs are grossly elevated in acute leukemias, but they can be normal or somewhat slightly elevated in chronic leukemias. In adults or elderly, usually in both the conditions, most of the faculties are answering it as the best answer. Okay. In elderly, it is much more common. Definitely, previously it was CML more common in adults, and elderly में CLL. Now they are answering CLL for both of them in most of the cases. Sorry, excuse me. So here definitely the WBC count would be elevated, and which is predominantly seen. So please remember, there would be a predominant rise in the B lymphocytes. There would be predominant rise in the B lymphocytes or the B cells, and the B cell would be more than 5,000 cells per cubic millimeter. Okay, so the B cell count would go to more than 5,000 cells. So out of the total WBCs, mainly B cells are elevated. And how much is the B cell count? More than 5,000 cells per microliter usually. Okay. Sorry. Now, what is the investigation of choice? If you are suspecting leukemia, chronic lymphocytic leukemia in the patient, what is the investigation of choice? Jaldi. What is the investigation of choice? So now you need to confirm whether these elevated cells are definitely B cells or not. So you will check for the B cell markers, and these B cell markers are CD markers, right? And the investigation, very good, Vishal. The CD markers are checked by an investigation known as flow cytometry. It is checked by an investigation known as flow cytometry, right? And all the CD markers which will be positive are the B cell markers mainly, right? And B cell markers are 2-digit numbers. T cell markers are 1-digit numbers. So here, if I can write, T cell markers are usually CD1 to CD8. T cell markers are usually CD1 to CD8, whereas B cell markers are CD19 to CD25. Okay, whereas B cell markers are CD19 to CD25. Please answer me one question. Pan T cell marker and a pan B cell marker. Pan T cell marker, which would be positive for all T cells, and pan B cell marker, which would be positive for all B cells. This is the important one-liners from pathology. Till then, I'll tell you, on flow cytometry in CLL patient, there would be CD19, CD20 dim positivity, CD21, okay, CD23, and CD25 positivity as well. Along with that, this is important, CD5 positivity is seen. So you would say, sir, you are talking that there is predominant rise in the B cells. So why CD T marker is rise? So please remember, this is an important feature that you need to remember. All the B cell markers are elevated, CD19, 20, 21, 23, 25. But along with that, a T cell marker is also elevated, that is CD5 in this patient, CD5. Okay? Very good. Pan T cell marker is CD3. Pan T cell marker is CD3, whereas pan B cell marker is CD19. Pan B cell marker is CD19. Important one-liners from pathology you need to remember. Okay? Now, please tell me, what is the treatment of, what is the drug of choice for CLL patients? What is the drug of choice for patients of chronic lymphocytic leukemia? The drug of choice for chronic lymphocytic leukemia would be drug of choice for chronic lymphocytic. Very good, Dr. K. Dr. DK, sorry. It is fludarabine. If you need to answer one drug, the drug of choice for chronic lymphocytic leukemia is fludarabine. Drug of choice for chronic lymphocytic leukemia is Fludarabine. Drug of choice for chronic lymphocytic leukemia is fludarabine. If they ask you about the chemotherapy regime, then it is either the FCR regime or the PCR regime. What do you mean by FCR or PCR? So F is fludarabine, C is cyclophosphamide, and R is rituximab. Okay, fludarabine, cyclophosphamide, and rituximab. And PCR is pentostatin, cyclophosphamide, or rituximab. At least remember fludarabine as a drug of choice, and remember this R. R is a drug known as rituximab, and this has been asked. Rituximab is a monoclonal antibody against. It is the monoclonal antibody against the B cells. Okay, it is the monoclonal antibody against CD20. Okay, or CD19. So it is actually a monoclonal antibody against the B cells. Now, if they ask you what is the treatment of choice, what would be your answer? What is the treatment of choice? Anybody? What is the treatment of choice? The treatment of choice would be the best treatment. Very good. Allogenic bone marrow transplantation. It would be an allogenic bone marrow transplantation. What do we mean by allogenic? That means from the same species, from mother, father, or siblings. Okay, usually. So allogenic bone marrow transplantation would be the treatment of choice in this condition. Okay. If they ask you about the classifications, remember two names for classification depending on the risk. Okay, low, intermediate, and high risk. Usually CLL can be classified as Rye-Savitsky classification. It would be classified according to the Rye-Savitsky classification, and the second one is usually a Binet classification. So the two classifications which are seen in cases of CLL, first is the Rye-Savitsky classification, and second is the Binet's classification. Rye-Savitsky and Binet and Rye-Savitsky classification. Then please answer me, a patient of CLL is now having a high-grade lymphoma. So there is a transformation seen. What is this known as? This is a one-liner again. A transformation seen in a patient of CLL, which is transforming into a high-grade lymphoma. This is known as what? This is known as, important one-liner. Very good. Richter transformation. This is known as the Richter syndrome or the Richter transformation. Jo bhi bolna chaho, okay? It is known as the Richter transformation or the Richter transformation. Okay, no issues with this. Important. Very good. You need to remember this one liner. Next question over here, guys. It says a 60-year-old patient presents with fever, weight loss, extensive pruritus, and left upper quadrant discomfort. On examination, a massive splenomegaly was noted. Drug of choices. So first of all, the diagnosis over here is definitely CML, that is chronic myeloid leukemia. And chronic myeloid leukemia is more common between 50 to 60 years of age group. Chronic myeloid leukemia is more common between 50 to 60. So CLL 60 to 70, whereas CML 50 to 60 years of age group. Okay, in adults around 40, 50, 60 years of age group, it will definitely present with features. There would be fever, there would be weight loss. Again, the category B symptoms or TB constitutional symptoms like fever, weight loss, anorexia, all of these would be seen. And there is extensive pruritus. Why is there extensive pruritus? So it is chronic myeloid leukemia. That means the cells of the myeloid lineage are increasing, and the cells of myeloid lineage are all your granulocytes, neutrophils, eosinophils, basophils. So one out of them are definitely your basophils, right? So if basophils increase, okay, if basophils increase, they will release histamine, and excess of histamine release can cause extensive itching or pruritus in this patient. Okay, basophilia is seen. So basophilia is seen usually in the patient, and extensive release of histamine can cause flushing, secretory diarrhea. There can be extensive pruritus in the patient. So all of these are usually seen. Volume is low. I can just raise my voice, okay, somewhat. So definitely, along with all these features, there would be a predominant basophilia. Over there, we were seeing increased levels of B lymphocytes in CLL. Here we are seeing increased levels of basophils usually. Okay, predominantly basophilia is seen. All the other myeloid cells would also be increased. There would be increased number of neutrophils also, increased number of eosinophils also. Therefore, if I talk about a peripheral blood smear, on this peripheral blood smear, you can see all the granulocytes. All the granulocytes usually, that is your neutrophils or your eosinophils and basophils, are increased. Okay, there would be numerous granulocytes which are seen. So increased number of myeloid cells are usually seen. Increased number of myeloid cells are seen on a peripheral blood smear on a bone marrow biopsy. Right? Important is this one. You need to remember this. Now, please remember, usually CML or chronic myeloid leukemia, MOT cells are a different feature. I discuss about that. Chronic myeloid leukemia, please remember, guys, it will usually show a triphasic course. Okay, chronic myeloid leukemia usually shows a triphasic course. Means what? There would be three phases of chronic myeloid leukemia. The first one is actually called as the chronic phase, when in the bone marrow, the level of blast cells, okay, the level of blast cells would be less than 10%. Chronic phase mein, the level of blast cells are less than 10%. Then is the accelerated phase. When in bone marrow, the number of blast cells is between 10 to 19%. Okay. When the number of blast cells within the bone marrow is 10 to 19%. Whereas last is the blast crisis phase. Where there would be number of blast cells in the bone marrow would be more than 20%. It would be more than 20%. So you said in bone marrow, if the number of blast cells is more than 20%, it is considered as acute leukemia. Yes, it is considered as acute leukemia. But in chronic myeloid leukemia, on a long term, if the patient has exacerbation, okay, or there is worsening, so here also there is a phase known as blast crisis, where there would be increased levels of immature or blast cells more than 20% in the bone marrow. Okay? So chronic phase less than 10% blasts, accelerated phase 10 to 19% blast crisis more than 20% blasts. Okay, so all of these features are seen. Along with that, an important feature they have mentioned is massive splenomegaly. In all the other leukemias, massive splenomegaly is not noted. Splenomegaly can be seen, but not massive splenomegaly. Massive splenomegaly is seen in chronic myeloid leukemia. Please let answer two of my questions. Massive splenomegaly is also seen in a condition where there is crumpled tissue paper appearance, and second, massive splenomegaly is also seen in a condition which is endemic in Bihar and where there is fever in the patient. So please answer those two questions. So massive splenomegaly is seen in three conditions. Chronic myeloid leukemia, very good. Now, Dhanasai Priya, it is Kala Azar, and third is Gaucher's disease. So massive splenomegaly, three important conditions you need to remember. First is chronic myeloid leukemia. Second is Kala Azar. And third is Gaucher's disease. No issues with this. Important, you need to remember this. Now, I hope all of you are quite aware. If I will perform a workup of this patient, definitely the TLC count would be elevated. The total leukocyte count would be elevated on investigations. Okay, so the TLC count would be highly elevated, and predominantly there would be presence of basophils. Predominantly there would be a rise in the basophils in this patient, right? What is the investigation of choice to confirm? What is the investigation of choice, anybody? The investigation of choice for CML would be, so here I actually need to look for the genetic mutation. So CML can be due to multiple causes. It is usually due to some genetic translocations, or it can also occur due to radiation exposure or benzene intake as well. Very good. For cytogenetics, those to actually visualize those chromosomal translocations, I need to perform FISH in the patient. Okay, that is fluorescent in situ hybridization. Investigation of choice would be fluorescent in situ hybridization. For chromosomal translocation. And if I need to look for the genetic translocation, the genes, then it would be a polymerase chain reaction. Okay, very good. For molecular evaluation, PCR would be done in this patient, right? Important. Now, which translocation is seen? All of you are quite aware of this, and this is a repeated question multiple number of times. So the translocation which is seen in cases of chronic myeloid leukemia is between the long arms of chromosome number 9 and chromosome number 22. So translocation 922, where a hybrid oncogene is formed, and this oncogene is called as BCR-ABL1 gene. Okay, this hybrid oncogene formed is known as the BCR-ABL1 gene. So which chromosomal translocation? 922. Which chromosomal translocation? 922. Which genetic translocation? BCR-ABL1 gene. Which genetic translocation? BCR-ABL1 gene translocation. Repeat after me. Please remember this. Okay. So now please remember, when this gene is formed, this oncogene will activate an enzyme known as tyrosine kinase. And when tyrosine kinase is activated, there would be extensive and uncontrolled proliferation of these malignant cells of leukemia. Okay? Important. So understand this phenomena. And this translocation would be checked or assessed with the help of FISH, fluorescent in situ hybridization. What is this 922 translocation called as? Anybody? Which chromosome it is called as? So the 922 translocation is called as which chromosome? Anybody? Jaldi say. This 922 translocation is called as which chromosome? Very good. It is known as the Philadelphia chromosome. So Philadelphia chromosome is due to translocation 922, and it is a cause of which type of leukemia? Chronic myeloid leukemia, CML, in a patient. Okay. Now please let me know what is the drug of choice. What is the drug of choice in this patient? So tyrosine kinase inhibitors can be given to this patient, right? And the tyrosine kinase inhibitors which can be given to this patient are drugs like, very good, all of you, imatinib mesylate. Okay, so the drug of choice would be imatinib imatinib भी याद रख सकते हो बस, ठीक है. So the drug of choice for CML would be imatinib. Drug of choice for CML would be imatinib. But if the patient is unresponsive to imatinib or there is a resistance, so resistant CML which is not responding to imatinib, so we can give a second generation tyrosine kinase inhibitor. So I am just covering pharma also, so important, very good, it is bosutinib, very good, it is bosutinib. So please remember, drug of choice for CML, imatinib, which is a tyrosine kinase inhibitor. But if the patient is resistant to imatinib, the other drug which is used is bosutinib. The other drug which is used is bosutinib. Please remember this. And if they ask you treatment of choice, so usually treatment of choice would also be answered as tyrosine kinase inhibitors. Why? Because almost 85 to 90% cases of CML are responding to tyrosine kinase inhibitors, that is to the imatinib therapy. Okay? So very good results are seen with imatinib therapy itself. Okay? No issues with this. I hope so. I have answered all of these questions, right? So now moving further, guys, talking about the next one, and a very important question again. So here a 60-year-old male is presenting to you. Again, a patient between 50 to 60 years of age would come to you. Okay, so 60-year-old male presents to you with bone pain, which is the most common symptom. Okay, there would be fatigue in the patient, weakness. So fatigue, weakness or pallor in the patient is more likely due to anemia in the patient. There would be petechia in the patient. Petechia usually due to thrombocytopenia in the patient. That means there is decreased amount of platelets, decreased amount of RBCs. Okay, and there is hepatosplenomegaly also. Excess of destruction of these blood cells will cause hepatosplenomegaly. Massive splenomegaly, CML, but hepatosplenomegaly, all other type of leukemias, hepatosplenomegaly can be noted. On examination, lymph nodes are enlarged. Again, lymphadenopathy is a common feature to all of the types of lymphadenopathies, all of the types of leukemias. So lymph nodes are enlarged. That means there is lymphadenopathy in the patient. Okay. So what can be done? We can perform a peripheral smear or a bone marrow biopsy. If we perform a bone marrow aspiration or a bone marrow biopsy, on that, if I can see these type of myeloblast, immature myeloid cells are called as myeloblast. Immature myeloid cells are called as myeloblast. And if they are more than 20%, so it is suggestive of acute myeloid leukemia. Okay, if myeloblast on bone marrow aspiration or biopsy are more than 20%, it is suggestive of acute myeloid leukemia. But you would say myeloblasts are immature cells. They can be seen in CML also. So how to recognize them first of all? So please remember, immature cells usually they will have, these myeloblasts will have some eosinophilic granules or pinkish granules in their cytoplasm. And what are these granules called as? Important. This is the differentiating feature and you need to remember it. Pinkish or eosinophilic granules in the cytoplasm of myeloblast, to recognize them as myeloblasts, these are known as what? It is the hallmark feature of AML. Very good. It is the hallmark feature of AML. These are your OR rods. These are known as your OR rods. Okay? No issues with this. So OR rods on a bone marrow biopsy inside the cytoplasm of myeloblast is definitely suggestive of a acute myeloid leukemia in a patient. And to confirm once again, we can also stain these myeloblasts with myeloperoxidase. So myeloperoxidase positive are usually myeloblasts, whereas PAS positive are lymphoblasts. So please remember, to differentiate whether it is AML or ALL, first thing to differentiate is definitely presence of OR rods in the cytoplasm. It would be myeloblast. Second, to confirm, we can also stain these cells with myeloperoxidase. If they are MPO positive, it is myeloblast. If they are PAS positive, they are lymphoblast, periodic acid shift stain. No issues with this, anybody? Just a minute. Okay. Now moving further, in acute myeloid leukemia, guys, definitely here the diagnosis is AML. And in acute myeloid leukemia, definitely there would be a rapid onset of symptoms, or there would be a very stormy onset of symptoms. The causes can be multiple, but what is the most common cause of AML? So please remember, the most common cause of AML is usually idiopathic. Most common cause of AML is usually idiopathic. Apart from that, definitely radiation exposure can be a cause. Some cytotoxic drugs like anti-cancer drugs. So please remember, anti-cancer drugs are given to treat some malignancy, but they can cause leukemia in a patient. So this is called a secondary malignancy. So please remember, anti-cancer drugs can also lead to secondary malignancies, and the drugs name have been asked from pharma. These are usually your topoisomerase inhibitors. Okay, so topoisomerase 2 inhibitors are usually can lead to malignancies, or some alkylating agents. So topoisomerase inhibitors or alkylating agents can also be a cause of leukemia in a patient. Mainly they cause acute myeloid or acute lymphoblastic leukemia in a patient. Apart from that, definitely radiation exposure is also an important cause. and some genetic translocation also. I'll talk about the genetic translocation. Important, please let me know. First question, radiation exposure can lead to all types of leukemia except for leukemia. Leukemias can be caused due to radiation exposure. All types of leukemias are caused by radiation exposure except for which leukemia is never caused by radiation exposure. And that is important one liner. Then apart from this, the other causes can be Fanconi anemia, which is a congenital aplastic anemia in a child. Okay, that can also lead to acute leukemia in a patient in adulthood usually, right? And a very important genetic translocation you need to remember, that is translocation between chromosome number 15 and 17. So translocation 15, 17 and the genes known as PML RARA. So translocation 15, 17 or the PML RARA gene translocation. Please answer this question also. It is associated with which variety of AML? It is associated with which variety of AML? Very good, Dhanasai Priya. Important. All leukemias can be caused by radiation exposure except one, and that is CLL. CLL is never caused by radiation exposure. CLL is never caused by radiation exposure. Important. Okay? So it is never caused by radiation exposure, guys. Please remember this. Answer my next question that I asked you, please. So it can never be caused by radiation exposure in the patient. Okay? So see, PML RARA translocation or translocation 15, 17 would be causing which type of AML? Would be causing which type of AML? Anybody? They would be causing just a minute, guys. Very good. They would be causing M3 variety of AML. Very good. They would be causing M3 variety of AML, and that is acute promyelocytic leukemia. They will be causing M3 variety of AML, and that is acute promyelocytic leukemia. So I hope all of you are quite aware there are total 8 varieties of AML from M0 till M8. Which is the most common type of AML? The most common type of AML would be, Jaldi say, most common type of AML is, very good, M2. Most common type of AML is M2. Most common type of AML is M2. That is AML with some maturation. AML with some maturation or M2 variety is the most common type of AML. Which AML is associated with Down syndrome? Which AML is associated with Down syndrome? Jaldi answer karo. Very good. It is the M7 variety. That is acute megakaryocytic leukemia. Which AML is associated with Downs? M7. Which AML is associated with Down syndrome? M7 variety. That is acute megakaryocytic leukemia. Then which AML is associated with DIC? Disseminated intravascular coagulation or consumptive coagulopathy, as it is called as. DIC can be due to sepsis, trauma, abruptio placentae. It can also be due to leukemia. So DIC is more commonly associated with M3 variety of AML, that is acute promyelocytic leukemia. Okay, DIC is associated with acute promyelocytic leukemia. And which AML is associated with gingival hypertrophy or gum hyperplasia? So gum hyperplasia or gingival hypertrophy, it is usually seen with which variety of AML more commonly? Very good, it is the M5 variety. 4 and 5 can be the causes. More common it is M5. More common it is M5. ठीक है? So jaldi say most common type M2. Most common type M2. Associated with Downs M7. Associated with Downs M7. DIC M3. 3 letters, type 3. Okay, more DIC M3. Gingival hyperplasia M5. Gingival or gum hyperplasia M5 variety. No issues with this, anybody? Now answer my one question. Most common type of leukemia in Down syndrome. Most common type of leukemia in Down syndrome in children. Most common type of leukemia in Down syndrome children. CLL कैसे हो सकता है यार? ALL. Very good. ALL. Okay, ALL. It cannot be CLL. CLL is common in 60 to 70 years of age group. इतना तो lifespan भी नहीं होता Down syndrome वालों का. Down syndrome die usually people at a bit less than 50 years of age group itself. So the most common type in Down syndrome children is ALL, acute lymphoblastic leukemia. But if they ask you which type of AML is associated with Downs, then your answer would be M7. Okay? Most common overall ALL, most common type of AML is M7. Okay? This is the difference. Most of us tend to mark it as M7 AML only. Okay? So important, please remember this. Now please let me know what is the investigation of choice. Okay, once I have spoken about the types of AML, what is the investigation of choice for AML, diagnosing AML? Features I have talked about, there would be pancytopenia in the patient. On workup, there would be elevated levels of TLC. Okay, there would be excess of TLC count. So the total leukocyte count would be excessively high, and that can cause leukostasis in the patient. Leukostasis, it will increase the viscosity of the blood, okay, excess of leukocytes, and that will cause decreased or sluggish circulation to the brain or to the lungs as well. And therefore, the patient will have dyspnea. There can be CNS symptoms like confusion, encephalopathy. Okay? So blood supply is usually decreased to these organs due to excess amount of excess amount of leukocytes in blood, which increases the viscosity. Okay? So this is more commonly associated with AML. This is a special feature. That's why I'm telling you. Leukostasis is a feature more commonly associated with AML. Investigation of choice, all of you are right. It is bone marrow aspiration or bone marrow biopsy. So bone marrow aspiration or bone marrow biopsy. What is the best site to take bone marrow biopsy? The best site to take bone marrow biopsy would be. Best site to take bone marrow biopsy is usually. And for bone marrow biopsy, definitely we can use such a metallic needle, okay, a metallic reusable needle, which is known as the Klima needle. So needles bhi aa chuke exam mein pehle. So for bone marrow biopsy, we can use a reusable metallic needle known as Klima needle and a T-shaped needle, a plastic T-shaped needle, which is known as the Jamshidi needle. This is known as the Jamshidi needle. So the two needles you need to remember for bone marrow biopsy. First is the Klima needle, a metallic one, and second is the T-shaped plastic needle known as the Jamshidi needle. So please remember, it is usually the posterior superior iliac spine. Okay. Yeah, tibia can be used in children. Usually for adults, it is the posterior superior. AML is more common in adults, so it is the posterior superior iliac spine. Okay. So posterior superior iliac spine, PSIS, is the most common site for bone marrow aspiration, followed by iliac crest. Okay. Please let me know. Iliac crest is the best site for. Iliac crest is the best site for. Iliac crest is the best site for. Okay. So on bone marrow aspiration, as I told you already, in the picture you can see there would be presence of more than 20% myeloblast, which is diagnostic of AML. These myeloblasts would be MPO positive, and there would be presence of OR rods, cytoplasmic pinkish color granules known as OR rods, okay, which confirms our diagnosis definitely. So very good. For bone grafting, the best site would be iliac crest. For bone grafting, the best site would be iliac crest. Important hai, surgery se yaad rakh lo. Okay. What is the treatment now? So for all types of AML, the treatment would be different. Whereas for M3 AML, that is your acute promyelocytic leukemia, the treatment would be different. Okay. For acute promyelocytic leukemia, due to translocation 15-17 or PML-RALA translocation, the treatment of choice would be, the treatment of choice for M3 variety would be ATRA. Very good. The treatment of choice for M3 variety would be ATRA. That is all trans retinoic acid. Why? Because please remember, if you give other anti-cancer drugs to the patient, there would be killing of these cancer cells, and that can cause excessive release of OR rods in the circulation, and that will lead to DIC in the patient. So high risk of DIC is associated with M3, and therefore in M3 variety, the drug of choice would be ATRA, all trans retinoic acid. Along with that, definitely we can give arsenic trioxide to the patient. Even we can give arsenic trioxide along with it. But the single drug of choice is definitely all trans retinoic acid or ATRA. For others, it is usually cytarabine plus anthracyclines. For other types, it is cytarabine plus anthracyclines. Anthracyclines are drugs like, please let me know, anthracyclines, these are the most cardiotoxic anti-cancer drugs. Anthracycline group of drugs are the most cardiotoxic anti-cancer drugs. And these are drugs like, anthracyclines are drugs like, very good, doxorubicin and daunorubicin. These are drugs like doxorubicin and daunorubicin. Now, last type of leukemia that we need to discuss, guys. Here they have given a 5-year-old child. So if it is a child, definitely a diagnosis becomes much easier, because all other types of leukemia are common in adults. But to confuse you at times, please remember, to confuse you at times, they can even give you a 50-year-old patient over here. Because please remember, this type of leukemia, that is your ALL, is more common between 2 to 8 years of age group, as well as it can also be seen after 50 years of age group. It can also be seen after 50 years of age group, though it is much more common in children, but it can also be seen. Okay, don't directly rule it out from your options, but more commonly they won't confuse you with such things. It would more likely be a children between 2 to 8 years of age group. Commonly the patient will have rapidly progressive pallor. Okay, so again, as I told you, again, it is an acute leukemia. So the symptoms would be rapidly escalating. There would be a rapid onset or a sudden onset of symptoms, and there would be a progressive pallor, which is seen. Pallor, fatigue, all of these are usually due to anemia in the patient. There can be bone pain in the patient. So bone pain is characteristic in acute leukemias. Usually it is your AML or your ALL. Bone pain is very characteristic in this condition. And there would be hepatosplenomegaly. It is seen in all the types of leukemias usually. Even the patient can have lymphadenopathy as well, as I told you. Apart from that, two important things that you need to remember for ALL, and they are very specific to ALL: dissemination into the CNS. Okay, so dissemination into the CNS is commonly associated with which type of leukemia? So it is associated with ALL, that is your acute lymphoblastic leukemia. So the diagnosis is acute lymphoblastic leukemia. It is the most common type of leukemia in children. Okay, please remember. And usually, sorry, it is associated with CNS dissemination. That means there would be spread of these malignant cells in the CNS or the brain. So the patient can have even CNS manifestations like seizures, ataxia, okay, neurological deficit. All of these can be seen. So if such type of features are seen with leukemia, it is more likely to be a feature of ALL. And second, on palpation of the testis, okay, on palpation of the testis, a mass can be felt in this patient. So there can even be testicular dissemination as well. There can also be spread of these malignant cells into the testis as well. So there would be a testicular mass. So these are two characteristic features of ALL. First is CNS dissemination, second is testicular mass. First is CNS dissemination and second is testicular mass. Along with that, as they have told you about bone pain. So whenever you will take the child or whenever you will touch the child will cry in excessive pain. Okay. And whenever you will pick up the child and you will press the sternum, usually there would be a very excruciating pain seen in the child, and that is called as the sternal tenderness. This is a characteristic statement they give you in question. Child having sternal tenderness along with all other features, definitely ALL in a patient. Child having anemia, thrombocytopenia and sternal tenderness, definitely you need to think in terms of ALL, acute lymphoblastic leukemia in a patient. This is characteristic usually. What is the investigation of choice in ALL? Yeah, petechia, as I told you, thrombocytopenia would be there. So petechia can also definitely develop in a child. Okay. Definitely, investigation of choice is a bone marrow aspiration or a bone marrow biopsy. Investigation of choice is again a bone marrow aspiration or a bone marrow biopsy. Here, definitely we can prefer the tibia, and again, it would be your Kleiner needle or your Jamshidi needle. Okay, Kleiner or your Jamshidi needle, which are used for bone marrow aspiration in this patient. And on bone marrow aspiration, such kind of a picture is seen where there would be these kind of cells having a very large nucleus, and cells having a large nucleus without presence of any granules. These are usually your lymphocytes, right? But these are immature lymphocytes, therefore called as lymphoblasts. These are usually called as the lymphoblasts, and lymphoblasts more than 20% are diagnostic of ALL. Lymphoblasts more than 20% are diagnostic of ALL. Please let me know, usually lymphoblasts are stained with which stain? As I told you, myeloblasts are stained with myeloperoxidase. Lymphoblasts are stained with, as I told you already, lymphoblast would be stained with which stain? Lymphoblast would be stained with, very good, pass positive. They would be pass positive. Periodic acid shift, they would be pass positive. Okay, so if they are pass positive lymphoblast on bone marrow biopsy more than 20%, definitely it is a case of ALL, acute lymphoblastic leukemia in the patient. There would be CNS dissemination. There can be features of meningismus. There would be a testicular lump or testicular mass on palpation, on all these features that we have discussed. What is the drug of choice or the treatment regime that we prefer? So definitely we will give a chemotherapy in this patient, and the treatment regime which is preferred is valve regime. The treatment regime which is preferred is valve regime. VAPD भी easy है, valve मेरे हिसाब से तो एक ये हो जाता है. So valve regime, V goes for vincristine, V goes for vincristine, V goes for vincristine, A goes for anthracyclines, A goes for anthracyclines, and anthracyclines we discussed. These are drugs like daunorubicin, idarubicin. Okay, these are drugs like daunorubicin or idarubicin. Then L goes for L-asparaginase. L goes for L-asparaginase, and P goes for steroids, that is prednisolone. P goes for steroids, that is prednisolone. So the chemotherapy treatment regime used for ALL is valve. Chemotherapy treatment regime used for ALL is valve. V for vincristine, V for vincristine, A for anthracyclines like daunorubicin, A for anthracyclines like daunorubicin, L for L-asparaginase, L for L-asparaginase, and P for prednisolone, P for prednisolone in the. Along with that, if the patient is having CNS manifestations also, there is CNS dissemination. What should be given? Which drug is given for CNS leukemia? For CNS leukemia or for meningismus patient, what is usually given? We will give some drug in the CSF, into the cerebrospinal fluid. That is called as intrathecal. So which drug is given for CNS leukemia? Very good, intrathecal methotrexate. So the drug of choice for CNS leukemia is intrathecal methotrexate. Drug of choice for CNS leukemia would be intrathecal methotrexate. Along with that, CNS radiation can also be given to the patient. And please remember, in ALL patient, usually This valve regime is given as in the remission induction phase, then there is a continuation phase, and then there is a maintenance phase also. Okay, so it is a long therapy which is given for almost 2 to 5 years. Okay, depending on the severity. Now please let me know the most common malignancy. If I ask you, most common type of leukemia in children is definitely ALL, but the most common type of malignancy in children, anybody? Most common type of malignancy in children, anybody? I'm asking you the most common kind of malignant tumor or malignancy in children. Then your answer would be, very good. Again, your answer would be ALL. Okay, so most common type of malignancy in children, the answer remains ALL, acute lymphoblastic leukemia. It is so much common. Okay, it is so much common, followed by medulloblastoma. Okay, next, please tell me, here you can see on peripheral blood smear. Okay, on peripheral blood smear, if you are able to see these flower-like pattern, okay, so flower-like nucleus in a cell or a clove leaf pattern is seen. Okay, so flower cell is seen. Oh, sorry. A flower cell is seen or a clove leaf pattern is seen, or clove leaf pattern is seen of a nucleus in a lymphocyte. It is more likely suggestive of, so definitely it is a lymphocyte having a very large nucleus, but this nucleus is having a flower-like pattern or a clove leaf-like pattern. So this is called as a flower cell or a clove leaf cell or clove leaf pattern of cell. This is a feature of, please remember, adult T cell leukemia. It is a feature of adult T cell leukemia. It is a feature of adult T cell leukemia. And adult T cell leukemia is due to a virus known as HTLV1, human lymphocytic, human T cell lymphotropic virus 1. Okay, human T cell lymphotropic virus 1. Whereas if this kind of a cell is seen, a patient presenting to you with diffuse redness of skin, that is erythroderma in skin, there is splenomegaly in the patient, there would be lymphadenopathy in this patient, and on examination or peripheral blood smear, this kind of a cell is seen. This is again a lymphocyte, but this lymphocyte is actually having a notch in the nucleus, right? This type of a cell is actually called as the Sézary cell. This type of abnormal lymphocyte is called as the Sézary cell. So what would be your diagnosis? Sézary cell in peripheral circulation, diffuse redness or erythroderma on skin, lymphadenopathy and splenomegaly. Definitely, very good. The diagnosis over here would be mycosis fungoides. Diagnosis word here would be mycosis fungoides. And mycosis fungoides is nothing but cutaneous T cell lymphoma. It is a cutaneous T cell lymphoma. It is a cutaneous T cell lymphoma. Derma se important condition hai. And when there is dissemination of mycosis fungoides, usually it presents with skin lesions first, but when it spreads via blood to all the other parts of the body. Okay, so dissemination of mycosis fungoides is called as, anybody? This was a question, one line of question. Dissemination of mycosis fungoides is called as. So mycosis fungoides is not a fungal infection. It is cutaneous or skin T cell lymphoma. On examination, there would be Sézary cells present on peripheral blood smear, and the dissemination of mycosis fungoides is called as Sézary syndrome. Dissemination of mycosis fungoides is called as which syndrome? Sézary syndrome. Okay, yaad rakh lena. Please remember this. Moving to your most favorite question of all times, and the examiners too. So here I am having a 65-year-old patient, either a male or a female, okay, presenting to you with low backache. Okay, the first diagnosis that will come to my mind is definitely multiple myeloma. The first diagnosis that comes to my mind is definitely multiple myeloma. Whereas if I told you young adult male coming to you with low backache, please let me know the diagnosis. The first diagnosis that comes to your mind after hearing young adult male with low backache. So these are classical questions. Very good. It is ankylosing spondylitis. So young adult male with low backache, ankylosing spondylitis, or elderly patient with low backache, multiple myeloma in the patient. So please remember, multiple myeloma is a plasma cell malignancy. Multiple myeloma is a plasma cell malignancy. What are plasma cells? So these B cells or B lymphocytes differentiate into plasma cells, and these plasma cells will lead to formation of antibodies, right? So these are what are plasma cells. But if there is malignancy of these plasma cells, it is called as multiple myeloma. Okay, so this plasma cell dyscrasia or malignancy is called as multiple myeloma, which is more common in elderly patient, and the most common symptom would be bone pain or low backache. The most common symptom of this condition is either low backache or bone pain, where they will describe. Okay, so why the patient is having bone pain? Because there would be osteolytic lesions of bone. Okay, so osteolytic lesions of the bone would be seen. So first of all, let's talk about the diagnostic criteria of these multiple myeloma. Before that, just I'll tell you these plasma cell, so multiple myeloma is a plasma cell malignancy, but these plasma cells which are formed, they are not normal cells, these are abnormal or malignant cells. And plasma cell ka kaam kya hota hai? Plasma cells function is to produce antibodies, and antibodies have heavy chain as well as light chain. But these plasma cells are themselves defective, so they will lead to production of defective antibodies. They will lead to production of defective antibodies, which will only contain the light chains, of antibodies. So defective antibodies are formed and which will only contain the light chain of antibodies. Okay, that is your kappa and lambda chains. What are the light chains of antibodies? Kappa and lambda chains. And when these light chains are excreted out in urine, important one-liner, previous year question. When these light chains are excreted out in urine, these are called as which proteins? Anybody? When these light chains of antibodies are excreted out in urine, these are called as which proteins? Anybody? Please answer it. Light chains of antibodies excreted out in urine are actually called as Benz-Jones proteins. Very good. It is the Benz-Jones proteins. Important question here. It is the Benz-Jones proteins, right? When they are excreted out in urine. No issues with this? Yaad rakhna. For diagnosis now. Okay. So definitely if these defective antibodies are formed, definitely the patient will have recurrent infections again, like pneumonia. Okay. The patient will have recurrent infections, right? So this is important to remember. For diagnosis, now 3 features are required. Okay, for diagnosis, 3 important features are required. If I perform a bone marrow biopsy, which is the investigation of choice. So on bone marrow biopsy or bone marrow aspiration, how much plasma cells would be seen? There should be more than 10% of plasma cells. So it is called as plasma cytosis. So more than 10% plasma cytosis on bone marrow biopsy. More than 10% plasma cytosis on bone marrow biopsy. Along with that, what is the second feature? So second feature is usually a M peak should be seen. And M peak should be seen on serum or urine electrophoresis. M peak should be seen on serum or urine electrophoresis. So if I talk about the electrophoresis picture which had come earlier, here you can see a normal serum electrophoresis picture. Okay, in serum, the most abundant protein is albumin. The most abundant protein of serum is albumin. The most abundant protein of serum is albumin. So albumin would be high. Then there would be alpha 1, alpha 2 globulin, beta globulin, and then the gamma globulins. So normally these gamma globulins are low, right? Gamma globulins are nothing but immunoglobulins are your antibodies, right? Gamma globulins are nothing but your antibodies. But in this, what is happening in multiple myeloma? There are excess of defective antibodies or light chains of antibodies being produced. Therefore, on an electrophoresis, there would be a peak which is seen. There would be a peak which is seen, and that is called as the peak of gamma globulins. This is known as the M peak, M spike, or the church spire appearance. Kya bolte hai isko? This is known as the church spire appearance. So it is called as either the M peak or the church spire appearance. So second diagnostic criteria is presence of this M peak or church spire appearance on the serum or urine electrophoresis. And the last thing is usually any one of the Kraft features. Last one is any one of the Kraft features. So what are the Kraft features? So please tell me, what are the Kraft features? First is hypercalcemia. So normal calcium levels is 9 to 11 milligram per deciliter. Okay, here the calcium levels would be high. So C for hypercalcemia, R for renal failure, in the patient. That means the serum creatinine value would be more in this patient. A for anemia in this patient. So anemia would be there due to destruction of RBCs. And B for bony lytic lesions. B can also be remembered for bleeding. Why bleeding? Because there is the damage of platelets. Thrombocytopenia bhi hota hai, right? So there is anemia, thrombocytopenia as well in this patient. So Kraft feature, jaldi se, any one of the Kraft features should be present. That is C for hypercalcemia, R for renal failure, A for anemia, and B for bony lytic lesions. Jaldi se, what are the 3 diagnostic features? First, on bone marrow biopsy, how many plasma cells? More than 10% plasma cells. On serum or urine electrophoresis, what should be seen? M peak, M spike, or the church spire appearance. And any one of which features? Myeloma defining events or Kraft features. C for hypercalcemia, R for renal failure, A for anemia, and B for bony lytic lesions. Bony lytic lesions are most commonly seen in which bone? This most of you mark wrong. Please let me know. Bony lytic lesions are most commonly seen in which bone? Anybody? The most common bone involved for bony lytic lesions. So these bony lytic lesions are usually due to activation of the osteoclasts. So as the osteoclasts are activated, there would be increased osteolytic action that will cause bony lytic lesions or destruction of the bone. Very good. Very good, Kavita. It is lumbar vertebra. Please remember, it is not the skull. Most of you tend to mark it as skull. It is not the skull. Okay. So the most common bone involved for bony lytic lesion is usually your lumbar vertebra, and therefore the most common symptom is usually low backache in the patient. The skull is the last bone to be involved, and when the skull is involved, there will be multiple punched out lesions. So please remember, not always it is important to remember only the image, because in last examination or in August also they did not give you the image. They just mentioned it that the patient is having on skull x-ray multiple punched out lesions. So always remember what this means. Multiple punched out lesions are usually seen. So multiple punched out osteolytic lesions on a skull x-ray. This is seen in case of multiple myeloma, and this is known as what? Raindrop skull. This is actually known as your raindrop skull. This is known as your raindrop skull, right? Or raindrop configuration of skull. Okay, no issues with this. I hope so. I have answered. Okay, yeah. Moving further now, if I talk about the bone marrow biopsy, I can also find two important histopathological features. And these two important histopathological features are due to accumulation of light chains within the cells. If these light chains accumulate inside the cytoplasm, so these intracytoplasmic accumulations are called as anybody? No, intracytoplasmic accumulation of light chains are called as the single accumulation. I'm not talking about the next one, the one that I have marked. Intracytoplasmic accumulation of light chains is called as Russell bodies. Intracytoplasmic accumulation is called as Russell bodies. Intracytoplasmic accumulation is called as Russell bodies. Whereas the intranuclear accumulation is called as, the intranuclear accumulation would be called as, the intranuclear accumulation is actually called as the Dutcher bodies. Intranuclear accumulation is called as the Dutcher bodies. Okay, so please remember, light chains can accumulate inside the cells, either in the cytoplasm or in the nucleus. So intracytoplasmic are Russell bodies. Repeat, intracytoplasmic are Russell bodies. Intracytoplasmic are Russell bodies, whereas intranuclear are Dutcher bodies. Intranuclear are Dutcher bodies. Okay, so intracytoplasmic and intranuclear. This is important to remember because they will ask you this. And whereas this image came in August examination, as you can see over here, accumulation of light chains of antibodies within the cytoplasm of the cell. Okay, and that leads to a formation of a grape-like vacuoles. So grape-like vacuoles seen within the myeloma cells. These are known as, very good, these are known as the Mott cells. These are known as the Mott cells. So this image came already. These are known as the Mott cells. Okay, no issues with this, anybody? Important. Okay, now what is the investigation of choice? Definitely the investigation of choice would be a bone marrow aspiration or a bone marrow biopsy. So investigation of choice is a bone marrow aspiration or a bone marrow biopsy. What is the screening test of choice, anybody? Investigation of choice is bone marrow aspiration or biopsy on which there would be more than 10% of plasma cells. What is the screening test of choice, anybody? The screening test of choice would be electrophoresis. Screening test of choice is either serum or urine electrophoresis. Okay, and what is the treatment, anybody? Serum or urine electrophoresis, both can be done. What is the treatment? So treatment here, you need to remember, it is as BLS. Okay, basic life support need. BLS goes for B for bortezomib. Okay, B goes for bortezomib, which is a protease inhibitor. B goes for bortezomib, which is a protease inhibitor. L goes for lenalidomide. L goes for lenalidomide. L goes for lenalidomide. And S goes for steroids like dexamethasone. L goes for steroids like dexamethasone in the patient. So BLS are usually given. The previous drug which was used was melphalan. So agar wo puchte hai, melphalan was used for. So melphalan was used for multiple myeloma. Remember the name at least. Pharma se important hai. Melphalan is used for multiple myeloma. No issues with this, anybody? BLS is the treatment regime which is given. Moving further, talking about lymphomas now. So if I talk about lymphomas over here we have a patient who is 30-year-old patient presenting to you with progressive cervical lymphadenopathy. 30-year-old patient presenting to you with progressive cervical lymphadenopathy, and there are category B symptoms. What do we mean by category B symptoms? All the constitutional TB symptoms. That means the patient will have fever. Okay, mainly evening rise of fever is usually seen. Then the patient can have loss of appetite. Okay, there would be loss of appetite. There can be night sweats in the patient, or there would be a weight loss. So involuntary or chronic weight loss in the patient is seen. Okay, so weight loss of more than 10%. In all other conditions, we consider involuntary weight loss of more than 5% is involuntary. But here in lymphomas, usually more than 10% of weight loss is required to consider it as involuntary. So more than 10% of weight loss over a duration of 6 to 12 months. Okay? So all of these category B symptoms. Then intermittent fever. So this intermittent fever is characteristic, which will rise for a period of 7 to 10 days. Then it will subside. Then it will again rise for a period of 3 to 7 days. Okay. What is this type of a fever called as? Anybody? This characteristic fever, intermittent fever seen in cases of lymphoma. Important one-liner. This characteristic fever seen in cases of lymphoma. Intermittent fever. It is called as, jaldi se, it is known as the Pal-Epstein fever. It is known as the, no, step ladder nahi hota. It is the Pal-Epstein fever. Very good, Dhanasai Priya. It is the Pal-Epstein fever. Okay, so please remember, it is the Pal-Epstein fever. Okay, Pal-Epstein fever, it is known as. Okay, so intermittent fever in cases of lymphoma. Please let me, step ladder fever kahan dikhta hai? Step ladder fever is usually a feature of typhoid or enteric fever. Step ladder fever is a feature of typhoid or enteric fever. All ek fever bata do. Picket fence fever is seen in. Picket fence fever is seen in. Picket fence fever is seen in which condition? Please let me know. And intermittent fever in cases of malaria is actually called as the tertian fever or the quartian fever. Okay, malaria mein tertian ya quartian fever dikhta hai. After every 3 days or after every 4 days it is seen. Okay, no issues with this. So please let me know about the picket fence fever. Till that, I'll move further. On examination, there is rubbery consistency of lymph nodes, and this is most important. Rubbery consistency of lymph nodes. Lymphadenopathy are seen in multiple other conditions, but if there is rubbery or rubber-like consistency of these lymph nodes, the diagnosis is more likely to be Hodgkin's lymphoma. The diagnosis is more likely to be Hodgkin's lymphoma. Okay, so the diagnosis, the more diagnosis is more likely to be Hodgkin's lymphoma. Okay. Okay, it is Hodgkin's lymphoma in the patient. So on Hodgkin's lymphoma, there can be, for clinical staging, which classification is used? For clinical staging of Hodgkin's lymphoma, which classification is used? Anybody? For clinical staging of Hodgkin's lymphoma, which classification is used? Anybody? For clinical staging of Hodgkin's lymphoma, which classification is used? Anybody? WHO classification is for the histopathological subtypes. Based on the biopsy or histopathology, there is a WHO modified real classification. No, FIGO nahi. Clinical staging ke liye it is the Ann Arbor classification for Hodgkin's as well as for non-Hodgkin's lymphoma. For clinical staging, it is the Ann Arbor classification. Important one-liner question has been asked. Ann Arbor classification is used for lymphomas. Ann Arbor classification is used for lymphomas, and it is used for clinical staging of lymphomas. This is used for clinical staging of lymphomas. There are 4 stages. Stage 1, when one group of lymph node is involved. Stage 1, when one group of lymph node is involved. Stage 2, when 2 groups of lymph nodes are involved, but on the same side of diaphragm. When 2 groups of lymph nodes are involved, only on the same side of the diaphragm. Stage 3, when 2 groups of lymph nodes are involved on opposite side of the diaphragm. When 2 groups of lymph nodes are involved on opposite sides of the diaphragm. And stage 4 is dissemination or spread. Okay? In Hodgkin's lymphoma, the spread is usually from one lymph node to the other. That is called as a contiguous spread. And therefore, there would be involvement of multiple groups of lymph nodes. It can be submental, submandibular, deep cervical. All of these lymph nodes can be involved in the patient. Even there can be involvement of the abdominal lymph nodes, which can compress the adjacent structures. Okay, they can compress portal vein, causing portal hypertension in the patient. They can compress the thoracic duct, causing chyloscystitis in the patient. Okay, that they can also compress the superior vena cava, causing SVC syndrome in the patient. So all of these would be seen in the patient. Okay, so whichever lymph node is involved, it can cause pressure symptoms also, along with all these features that we have discussed. Pal-Epstein fever, category B symptoms, and progressive cervical lymphadenopathy causing pressure symptoms in the patient. Clinical staging, we use the Ann Arbor classification based on the group of lymph nodes involved. And yes, based on the histological subtype, definitely, okay, based on the histological subtype, WHO has given us a real classification. WHO has given a modified real classification. So now, according to the WHO real classification, guys, please remember, Hodgkin's lymphoma can be classified as classical or typical Hodgkin's lymphoma. Hodgkin's lymphoma can be classified as classical or typical Hodgkin's lymphoma, and non-classical Hodgkin's lymphoma, and non-classical Hodgkin's lymphoma. Okay, please let me know. Non-classical Hodgkin's lymphoma is known as, non-classical Hodgkin's lymphoma is known as. Hodgkin's lymphoma, as you can see over here, the age group is important, guys. Please remember, Hodgkin's lymphoma has bimodal pattern of age distribution. It is common in 15 to 35 years of age group. It is common in 15 to 35 years of age group, and it is also seen in elderly patient, 50 to 60 years of age group. So it has a bimodal pattern of age distribution between 15 to 35 and elderly patients also. Please let me know the classical or non-classical patterns of Hodgkin's lymphoma. The non-classical pattern of Hodgkin's lymphoma is called as the nodular lymphocytic predominant variety. It is called as the nodular lymphocytic predominant Hodgkin's lymphoma. It is called as the nodular lymphocytic predominant Hodgkin's lymphoma, right? And why it is called as non-classical? Because please remember, all other types of Hodgkin's lymphoma would be CD15 and CD30 positive. All other types of Hodgkin's lymphoma would be CD15 and CD30 positive. But non-classical Hodgkin's lymphoma, it is called non-classical because it is not CD15 and CD30 positive. Rather, it is CD. Please remember, this is important. Please tell me what are the CD markers for non-classical Hodgkin's lymphoma or nodular lymphocytic predominant variety. This is important. It is usually CD20 or CD45 positive. It is usually CD20 or CD45 positive. So CD15 and 30, classical Hodgkin's lymphoma. CD20 or 45, non-classical Hodgkin's lymphoma, known as nodular lymphocytic predominant Hodgkin's lymphoma. And please remember, this nodular lymphocytic predominant Hodgkin's lymphoma has the best prognosis overall. It has the best prognosis. And second, which are the type of cells seen in nodular lymphocytic predominant? That is also the reason why it is called as non-classical. Because in classical Hodgkin's lymphoma, as you can see over here, we can see this classical appearance of cell which are having the owl eye appearance. Okay, in classical Hodgkin's lymphoma, we can see these cells having an owl eye appearance known as the RS cells, or the Reed-Sternberg cells, So Reed-Sternberg cells, RS cells, or the classical cells having owl eye appearance are a feature of Hodgkin's lymphoma. They are a feature of classical Hodgkin's lymphoma. But please remember, in cases of nodular lymphocytic very good, Dansai Priya. We have discussed this earlier. We will see popcorn cells. We have discussed everything about popcorn now. We will see popcorn cells or L and H cells. These are called as L and H cells. Okay? So don't get confused. It is the same name, L and H cells, or the popcorn cells they are called as. Okay. Whereas if I talk about the classical variety, which is the most common classical Hodgkin's lymphoma worldwide, Jaldi. Which is the most common classical Hodgkin's lymphoma worldwide? The most common classical Hodgkin's lymphoma worldwide is nodular sclerosing. It is nodular sclerosis. So please remember, most common type of classical Hodgkin's lymphoma worldwide is nodular sclerosis. Just don't remember nodular. Nodular dono hai, classical bhi hai और non-classical या atypical bhi hai. Okay, so please remember, it is nodular sclerosing variety. ठीक है? Which is the most common type in Indian population. Most common type of classical Hodgkin's lymphoma in Indian population. Very good. It is mixed cellularity. Okay. Which is the Hodgkin's lymphoma having best prognosis? As we discussed, it is non-classical Hodgkin's lymphoma or nodular lymphocytic predominant Hodgkin's lymphoma. Best prognosis is seen with nodular lymphocytic predominant. Which lymphoma has the worst prognosis? Please let me know which lymphoma has the worst prognosis. Lymphocytic rich or lymphocytic depleted? So it is usually lymphocytic depleted. So the worst prognosis is seen with lymphocyte depleted. Lymphocyte depleted type of Hodgkin's lymphoma, right? Now, please tell me what is the treatment of choice. Please let me know what is the treatment of choice. And maximum, please remember, maximum amount of RS cells are seen in mixed cellularity. Okay? Nodular sclerosing, we will usually have small cells known as lacunar cells. Okay, we will have lacunar. Very good. The treatment of choice would be chemotherapy plus radiation also is given. So it is the ABVD regime which is given. It is usually the ABVD regime where A goes for, right, radiotherapy is also given if it is localized, but if it is usually disseminated, then definitely we can give a ABVD regime where A goes for adriamycin, B goes for bleomycin, V goes for vinblastine, important, and D goes for decarbazine. No issues with anybody? Okay, I hope this has been clear. Last type of lymphoma now. Moving to this one. The question states a 65-year-old patient. Okay. The question states a 65-year-old patient. That means elderly patient. Don't dare to answer it as Burkitt's. Burkitt's lymphoma is more common in children. Okay. So a 65-year-old patient with multiple painless lymphadenopathy and category B symptoms. So again, category B symptoms like evening rising fever, loss of appetite, weight loss more than 10%, and night sweats usually are also seen over here. And there would be a history of flu-like episode with Epstein-Barr virus. What is the diagnosis? Definitely the diagnosis is a non-Hodgkin's lymphoma. The diagnosis is definitely a non-Hodgkin's lymphoma. So out of Hodgkin's and non-Hodgkin's, please remember, non-Hodgkin's lymphoma is very much common. Non-Hodgkin's lymphoma is very much common. Non-Hodgkin's lymphoma can either be B-cell lymphoma or they can be T-cell lymphoma. Which are common? Please let me know. Non-Hodgkin's lymphoma can either be B-cell or T-cell. They can be more common or one are B-cell or T-cell. Very good. These are the B-cell lymphomas which are much more common. Okay, B-cell non-Hodgkin's lymphoma are much common in the patient. Which is the most common type of B-cell non-Hodgkin's lymphoma? Which is the most common type of B-cell non-Hodgkin's lymphoma worldwide and in any organ? So the most common type of lymphoma in worldwide and in any organ. So the answer would remain same. It is easy. So if they ask you about any organ, most common type of lymphoma in stomach, in spleen, or any other organ, most common type of lymphoma in any organ, or most common type of lymphoma worldwide, it is to be answered as, jaldi say, it is to be answered as DLBCL, that is diffuse large B-cell lymphoma. Okay, it is to be answered as DLBCL, that is diffuse large B-cell lymphoma. Please remember this. Okay, important. Apart from that, definitely there can be other types of B-cell lymphomas also. There would be follicular cell lymphoma, there can be mantle cell lymphoma, there would be a marginal zone lymphoma. Okay, so all of these type of lymphomas are seen. And if a non-Hodgkin's lymphoma is seen in an African child, it is seen in an African child who is presenting to you with very rapidly progressing jaw mass, with a very rapidly progressing jaw mass or a jaw or a neck swelling. So it is usually due to lymphadenopathy. Okay, cervical lymphadenopathy. Okay, and if I take a biopsy of this patient, on biopsy usually I will find these type of pattern. What is this type of pattern? Here you can see the background is formed by all the malignant lymphocytes. Okay, the background is formed by all the small blue malignant lymphocytes, and in between of them we have these macrophages. Okay, glittering like stars. Okay, therefore it is known as the starry sky appearance. Okay, so starry sky appearance is seen on a lymph node biopsy. Okay, so starry sky appearance on a lymph node biopsy is a feature of which lymphoma? Very good, all of you. It is the Burkitt's lymphoma. So this condition is classically the Burkitt's lymphoma. Which are the translocations? So this is an important question. Which are the translocations? Burkitt's lymphoma can be genetic in nature, and the translocations seen in Burkitt's lymphoma are B looks like 8. So all the translocation involving chromosome number 8 are commonly associated with Burkitt's lymphoma. B looks like 8. Therefore, translocation 814, translocation 814, translocation 822, translocation 822, translocation 28, translocation 28. So all involving 8 are commonly associated with Burkitt's lymphoma. So which translocations are common with Burkitt's? Translocation 822, translocation 814, translocation 28 in a patient. Okay? And this will lead to activation of a gene known as c-MYC. That will cause activation of a gene known as c-MYC. So which is the oncogene activated in Burkitt's? c-MYC. Which is the oncogene activated in Burkitt's? It is the c-MYC gene mutation. Lymph node biopsy shows starry sky appearance. Jaldi se, just revising, starry sky appearance on NCCT head. Question number 1. Okay, starry sky appearance on NCCT head. Question number 2, starry sky appearance on ultrasound abdomen. Question number 2, starry sky appearance on ultrasound abdomen. And question number 3, starry sky appearance on immunofluorescence of kidney biopsy. Question number 3, starry sky appearance on immunofluorescence of kidney biopsy. Jaldi se answer karo. 1, 2, 3 mark karke answer mein that. Okay, so I hope we have covered Burkitt's lymphoma, right? So please remember, you need to think remember this. Definitely here on CBC or on a blood workup, the patient will have pancytopenia. In any case of non-Hodgkin's lymphoma, due to extensive proliferation of lymphocytes, the other cells will not get enough place to divide in bone marrow, and therefore, the other cells will not get enough place to divide. So there would be pancytopenia as well. There would be anemia, thrombocytopenia, as well as leukopenia would be seen. The investigation of choices, the excisional lymph node biopsy. So I have also marked in Hodgkin. So please remember, in Hodgkin's also the investigation of choice is a in excisional lymph node biopsy. In Hodgkin's also the investigation of choice is a excisional lymph node biopsy. Investigation of choice is a excisional lymph node biopsy in this patient on which this kind of a picture is seen. Okay, so please remember this. Very good, all of you. Kidney biopsy immunofluorescence, it is PSGN, post streptococcal glomerulonephritis, where we will see a starry sky or a lumpy bumpy appearance. Very good. Then on NCCT head, starry sky appearance is seen in neurocystic sarcosis, and in ultrasound abdomen it is acute viral hepatitis. Very good, BA. Very good, all of you, all of them who have answered. Okay, so very good, very good. Now, what is the treatment which is given over here? Sorry. The treatment which is given or used over here is known as R-CHOP. The chemotherapy regime which is used is known as R-CHOP, where R goes for an anti-B cell molecule. It goes for an anti-B cell molecule or an anti-CD20 molecule, or it goes for an anti-CD20 molecule known as rituximab. It is known as rituximab. Then C goes for anybody. C goes for cyclophosphamide. C goes for cyclophosphamide. H goes for hydroxydonorubicin. H goes for hydroxydonorubicin. Okay, H goes for hydroxydonorubicin or donomycin, you can say. Okay, O goes for oncovin. O goes for oncovin, and P for prednisolone. P goes for prednisolone. So R-CHOP regime is to be remembered. Okay, no issues with this. Lastly, now talking about this, and then hematology is over, guys. So jaldi say, now talking about pharma. Okay, I'm talking about pharma from hemat. Please tell me which is the antiplatelet drug. Okay, first we can discuss about antiplatelet drugs, and second are your anticoagulant drugs. So antiplatelet drugs act against the platelets, anticoagulant act against the clotting factors. So the antiplatelet drugs, if I talk about, which is the antiplatelet drug which will inhibit thromboxane A2. So thromboxane A2 causes platelet aggregation. So the drug which inhibits thromboxane A2, it is aspirin. Very good. The drug which inhibits thromboxane A2 is aspirin. It is a COX inhibitor. Please remember, it is a COX inhibitor. It inhibits the enzyme known as cyclooxygenase. It inhibits the enzyme known as cyclooxygenase. Okay, and it will inhibit the production of thromboxane A2. Then the next antiplatelet drug. The next antiplatelet drug. This time I know. I want to know the name of the receptor. Okay, so which receptor is inhibited by drugs known as clopidogrel or ticlopidin? Which receptor is inhibited by drugs known as clopidogrel or ticlopidin? Which receptors are inhibited by drugs known as clopidogrel or ticlopidin? Jaldi. Drugs known as clopidogrel or ticlopidin. Which receptors are inhibited? These are usually your ADP, P2, Y12 receptors. These are usually ADP, P2, Y12 receptors. Which receptors are inhibited by clopidogrel or ticlopidin? ADP, P2, Y12 receptors. This question has been asked. Okay, clopidogrel and ticlopidin inhibits which receptors? ADP, P2, Y12 receptors. And last one, which are the drugs which will inhibit the glycoprotein 2B3A receptors? As we discussed about glycoprotein 2B3A, Glanzmann thrombasthenia, yaad ho to. So the drugs which will inhibit the glycoprotein 2B3A receptors are drugs like, kya ho gaya sabko? The drug which is given in unstable angina or in NSTEMI. The first drug to be given, abemone mnemonic to diya tha, A for apiximab. So please remember, the drug is known as apiximab. Okay, eptifibatide is also one more drug. At least remember apiximab in the patient. Okay, so glycoprotein 2B3A inhibitor is apiximab. Glycoprotein 2B3A inhibitor is apiximab. Now talking about anticoagulant drugs. So antiplatelet drugs are definitely given in cases like myocardial infarction or in cases of prosthetic valve surgery, after prosthetic valve surgery, to prevent any clot formation in the patient. Okay, in cases of stroke or transient ischemic attack. In transient ischemic attack, the treatment of choice is dual antiplatelet therapy, aspirin plus clopidogrel. Okay, yaad rakhna. Then please let me know anticoagulant drugs now. Okay, anticoagulant drugs now, if I talk about, which will act against the clotting factors. So which is the oral anticoagulant drug of choice? Which is the oral anticoagulant drug of choice which is used for maintenance? Okay, the oral anticoagulant drug of choice which is used for maintenance. Pooch raha hu answer itni jaldi. The oral anticoagulant drug of choice. No, oral anticoagulant drug of choice used for maintenance. So maintenance mein har ek ko injection lagaoge. You will ask the patient to get injections every day for maintenance therapy for long term. Very good. It should be an oral drug known as warfarin. So the oral drug is warfarin. And warfarin will inhibit which vitamin? Warfarin is an antagonist to vitamin K. So warfarin is a vitamin K antagonist. Warfarin is a vitamin K antagonist. And vitamin K is responsible for activation. Vitamin K is responsible for activation of clotting factors. It causes gamma carboxylation of glutamic acid residues or gamma carboxylation of clotting factors 2, 7, 9, and 10. It causes activation of clotting factors 2, 7, 9, and 10. Therefore, warfarin will inhibit which clotting factors? 2, 7, 9, and 10. Warfarin inhibits which clotting factors? It will inhibit 2, 7, 9, and 10 clotting factors. Right? Important. So it mainly inhibits the clotting factor 7, as you can see. As it inhibits the clotting factor 7, therefore, which time would be prolonged? Bleeding time would be normal because it is not acting against platelet. Okay. APTT would be normal because it is not acting against the intrinsic pathway. It is acting against the extrinsic pathway. So therefore, which time would be prolonged? Very good. The prothrombin time would be prolonged because clotting factor 7 is present in the extrinsic pathway, and if clotting factor 7 is inhibited, the extrinsic pathway would be defective, which causes prolonged prothrombin time. There would be a prolonged prothrombin time in cases of warfarin overdose or warfarin toxicity. The other thing that you can check for is definitely INR, international normalized ratio. International normalized ratio. Warfarin, as we know, it is contraindicated during pregnancy, right? Warfarin is contraindicated during pregnancy because it causes microcephaly and nasal hypoplasia. It can lead to microcephaly and nasal hypoplasia in the patient, okay, in the fetus. This is called as the fetal warfarin syndrome. This is known as the fetal warfarin syndrome. Therefore, warfarin is contraindicated during pregnancy, but mainly during the first trimester. Okay, so first trimester, agar patient aata hai tumhare paas, definitely will change the patient to heparin. So this is a classical case. Okay, if a patient comes to you in first trimester, definitely we can change the patient. We will stop warfarin and start the patient on heparin. Okay, we will start the patient on heparin usually. A low molecular weight heparin would be started in the patient. Okay, but after that, if the patient is uncomfortable taking heparin injections, definitely after first trimester, you can start the patient on warfarin again. You can start the patient on warfarin again towards the end, but as the delivery comes nearby, okay, as the delivery comes nearby, 36 weeks, 37 weeks, you need to start the usually you need to start the patient again on heparin. Okay, as the delivery comes nearby, again at term, usually you need to switch the patient to heparin. Okay, so please remember this. Warfarin cannot be continued till delivery. And please let me know, ye case humne discuss kiya tha, and like definitely all of you are quite aware of pregnant female coming to you. A patient is on currently on warfarin therapy, and what should be done? So stop warfarin, start heparin in the patient. But I have given you a question in OBG, we discussed it. Ops, a patient comes to you in labor pains. A patient comes to you at term at 37 weeks in labor pains, and the patient is to be delivered. She is currently on warfarin therapy. What should be done? She is currently on warfarin therapy. What should be done? What should be done with the drug? And second, what should be the mode of delivery? What should be done with the drug, and what should be the mode of delivery in the patient? Jaldi se batao. We can give vitamin K to the patient. Very good. C-section. The mode of delivery would be C-section. We will continue warfarin. Very good. We will continue warfarin in the patient, give vitamin K in the patient to prevent any excessive hemorrhage or hemorrhagic disease of the newborn and fetus. So we will give vitamin K. Very good, Kavita. And we will perform a cesarean section, not a normal vaginal delivery, to avoid PPH in the patient. Okay? Yaad rakhna, this is a different condition. So they might ask you this. Okay? So now, then apart from that, if I talk about the next anticoagulant drug, which is the drug which will inhibit factor 2A. Factor 2A is also known as thrombin. So which are the direct thrombin inhibitors? Anybody? The direct thrombin inhibitors are drug like? The direct thrombin inhibitors are usually drug like? Direct thrombin inhibitors are drugs like? These are usually injectable. Only one oral drug is available. Direct thrombin inhibitors or direct factor 2A inhibitor. Jaldi. So these are drugs like heparidine or lepirudine. Okay, these are drugs like rudine drugs. Okay, heparidine drugs, lepirudine drugs, all of these. These are all injectables. The only oral and direct thrombin inhibitor, the only oral direct thrombin inhibitor is anybody. The only oral direct thrombin inhibitor is this. I need an answer because this was a recall question. Only oral direct thrombin inhibitor. Only oral direct thrombin inhibitor. Then I'll discuss about the next one. Okay, factor 10A inhibitors. The direct factor 10A inhibitors are, these contain XA in their name itself. Okay, these are drugs like apixaban or rivaroxaban. These are drugs like apixaban or rivaroxaban. So they contain factor 10A in the name itself. Okay, so these are drugs like apixaban or rivaroxaban. So factor 10A inhibitors, apixaban or rivaroxaban. Rivaroxaban, O aata hai iske naam mein, so therefore it is an oral drug. So oral factor 10A inhibitor, rivaroxaban. Oral factor 10A inhibitor, rivaroxaban. Others, apixaban vagara are injectable drugs. Okay, so factor 2A inhibitors or thrombin inhibitors, lepidolin, heparidine like drugs. The only oral drug to be given is dabigatran. The only oral drug given is dabigatran. So this is a recall question, guys. Please remember this. The only oral direct thrombin inhibitor is dabigatran in the patient. Whereas last one, if I talk about indirect factor 2A and 10A inhibitors, indirect factor 2A and 10A inhibitors, कौन सी drug होती है? Indirect factor 2A and 10A inhibitors, indirect factor 2A and 10A inhibitors, which will activate antithrombin first and then it will inhibit the factor 2A thrombin or the factor 10A. Very good. Indirect are heparin. Indirect is heparin in the patient. Okay, indirect thrombin inhibitor or factor 10A inhibitor is heparin. Heparin is available in various forms. It can be a low molecular weight heparin. Okay, it can be unfractionated heparin, or it can be fondaparinux, or it can be enoxaparin or fondaparinux. It can be fondaparinux in the patient. ठीक है, समझ जाओ. Fondaparinux would be there in the patient. ठीक है, no issues with this. Now, if I ask you the drug of choice for maintenance of anticoagulation, drug of choice for maintenance of anticoagulation, jaldi se. Drug of choice for maintenance of anticoagulation, jaldi. Drug of choice for maintenance of anticoagulation, which drug should be given? Warfarin. Very good, warfarin. Drug of choice for anticoagulation in pregnancy, drug of choice for anticoagulation in pregnancy, which drug to be given? Drug of choice for anticoagulation in pregnancy. Very good. It is heparin. It is heparin. Now, please let me know. Heparin, as we saw, for warfarin, PT or INR was seen. For heparin activity or heparin overdose, we need to check the APTT. Okay, we need to check the APTT in the patient. We will check for the APTT in the patient because usually it is inhibiting factor 10A and 2A. Okay, so APTT time would be prolonged in cases of indirect in cases of heparin overdose or heparin toxicity. Now, jaldi se bata do drug of choice for warfarin toxicity. Drug of choice for warfarin toxicity. Drug of choice for warfarin toxicity or warfarin overdose. Warfarin toxicity, the patient is not currently bleeding. If they ask you directly, the drug of choice for warfarin overdose or warfarin toxicity, if the patient is not bleeding, there is a bleeding tendency. Very good. It is vitamin K. Okay, it is vitamin K. If the patient is having increased bleeding, okay, so if the patient is having bleeding manifestations due to warfarin toxicity, then very good, your answer should be FFP, fresh frozen plasma. Then your answer should be richest source of clotting factors, that is FFP. But better than FFP, what is the answer? Better than FFP. Why give all the clotting factors? Only give the clotting factors which are inhibited, 2, 7, 9 and 10, and that is called as which complex? So the better answer would be 4-factor complex. The better answer would be a 4-factor complex or a prothrombin factor complex. A 4-factor complex or a prothrombin factor complex is given in cases of bleeding patients having warfarin toxicity. Drug of choice. This was a recall question now. Drug of choice for heparin toxicity. Drug of choice for heparin toxicity. Jaldi se. Drug of choice for heparin toxicity is, very good, protamine sulfate. Drug of choice for heparin toxicity is protamine sulfate. Drug of choice for heparin toxicity or antidote of choice for heparin toxicity is protamine sulfate in the patient, right? It is protamine sulfate. Okay? And this was a question in NEET PG. Drug of choice for dabigatran toxicity. Drug of choice for thrombin inhibitor toxicity or drug of choice for dabigatran toxicity. It is a monoclonal antibody. It is a monoclonal antibody. क्या पीते हो? Which monoclonal antibody? वही तो पता होना चाहिए ना. Idarucizumab. Okay, the drug is idarucizumab. It is idarucizumab. And for rivaroxaban toxicity, it is andexanet alpha. It is andexanet alpha. It is andexanet alpha. No issues with this. So I am done with this one, guys. Hematology. So just let me know. Tomorrow we don't have enough time, so I can just start with GIT. GIT is very small. As I told you, I'll not spend much time on GIT. I'll cover it most of the parts in this one, surgery only. Okay, I need to just I need to just join from this only. Okay, because I don't have the file over here currently. I'm not able to share the file. Just let me know in the chat box. Jaldi se batao. What is your take? Shall we continue? GIT jaldi se khatam kar le. It is not much. All of you would be quite aware of GIT. I hope so. अरे सो गए क्या सब के सब? Great. So we will continue. Just let me take the file. यार file ही नहीं आ रही है. Next second. I'll stop the share and start again. Just give me 5 minute time. तब तक पानी पी लो. 2-5 मिनट का टाइम दे दो. GIT short. I'm not taking liver. Liver would be done tomorrow, so don't worry. अगर सोच रहे हो कि hepatobiliary नहीं, hepatobiliary will be done tomorrow. So only GIT, so that would be only PUD वगैरह only. Okay, not much time would be taken of yours. Oh my goodness. Just a minute, guys. On my iPad, I don't have that file, so I need to open it on the Lappy as well, and I will write with the notepad. So I will send you the file again, rewritten file properly. ठीक है, अभी अगर थोड़ा बहुत writing में ये हो रहा है because I'm not used to this notepad now, so just adjust because I don't have it on the iPad. So I'll share it again. I'll write it on the iPad and then I'll share it again. Tomorrow, I need like I think there would be an offline class, and we prefer having offline class. If JSS class would not be there, definitely. ठीक है? Or at least we will have a class in our morning. Only endo and liver would be left. Okay, only endo and liver is left. No issues with that. So I'll share the screen and open the PPT now. General, yeah, I'll come back from Jaipur and then we'll do general in a short session. Okay, general path, general pharma. I'll do that when I come back from Jaipur, like second or third. Okay. Surgery would be in the first week of May for sure. Don't worry. After PSM, I'll start with surgery. I'm starting PSM first because most of you have completed your PSM, and PSM needs good revision, right? So I'll start with PSM and then with surgery. Biochem, this I'll try to upload it on YouTube as well. Biochem, please remember guys, Biochem ka funda ye hai ki I spoke to most of you. I spoke to most of them and they are saying that for biochem, definitely Priyan sir would also be coming. So I'll take anatomy instead of biochem. I am feeling so, because Priyanshu sir would be coming for TND also, and thereafter for QRS session also. So biochem would be done twice anyways. ठीक है? So guys, एक second, मैं notepad से नहीं, मैं iPad से ही connect करता हूँ, but I'm not able to get it. हाँ, file नहीं है. Just a minute, lend me some time. Okay. There's some problem with the Lappy because I'm not able to share the file as such, share the screen itself. Ortho and forensic. Forensic Dr. Vikas sir will continue. Ortho, I have taken TNDs, so I'll also try to take chanting. A short chanting session can be done for ortho and radio together. Okay? For ortho and radio, we will have together itself. Most of the things we'll discuss. Just a minute, guys. I'm having some issues in the Lappy. चाय वगैरह पी लो जल्दी से, थोड़ा सा शॉर्ट सेशन के लिए बस. यार पता नहीं क्या हो रहा है इसको. Shit. Just a minute, guys. Okay, okay. Yeah, it would be uploaded either on the app or on the YouTube channel. Don't worry about that. Okay. So don't you worry about that at all. Just a minute, guys. Just spare a minute. There are some problems that are arising now. There's some problems with the lappy. Sorry for the disturbance. That's the usual problem in online cases. Mm-hmm. The problem is actually now that the lappy is having issues. Otherwise, I would have mailed it previously only. So actually, the lappy is having a lot of issues. I'm not sure why. So I'm just connecting it again. From other source. Sorry for the disturbance here, but I hope you can understand the problems I am facing over here. Screen sharing is the actual problem. So guys, I'll start. Okay, I'll connect from the iPad itself and I'll start. Images would not be there. I'll send you the images afterwards. Okay, no issues with that. So I don't want to waste any time of yours. So I'll send the image file and I'll write over there and properly I'll send it to you like till evening itself. But now I'll continue without any further delay. Sorry. So yeah, I've connected my from all three devices. Just a minute. So I'll just start on Notepad itself. Okay. So guys, please let me know if you are able to see the screen properly. Okay. So let's start. No issues with this, anybody? No issues with audio visuals? Please let me know if the audio visuals both are clear, and let's start then. Great. Thank you so much. Thank you so much for understanding the issues and having that patience. So I am beginning with the GIT over here. We will only discuss about the important points of GIT. Okay. I hope all of you have revised all the other topics that we have discussed. Okay. So that would be easier for you to remember. Otherwise, it would be a lot of difficult thing if you keep on piling up the stuff, right? So it is important to revise it at the particular point itself. Don't delay the things for a very long time. So starting with gastroenterology, here a patient complains of abdominal pain. Here the patient complains of abdominal pain for 2 hours post meals, and there is hematemesis. Okay, there is hematemesis. What do we mean by hematemesis? That means there is blood and vomiting, right? So there would be hematemesis in the patient as well, which is the likely source of bleeding in this condition. What do you think? What is the diagnosis over here? What do you think? Which is the diagnosis over here? Right. So here the patient is having abdominal pain post meal. So please let me know if my voice is clear now. Here the diagnosis would be more likely a peptic ulcer disease in the patient. Okay, here, yeah, very good. The most likely diagnosis over here would be peptic ulcer disease in this patient, right? If I talk about peptic ulcer disease, either this can be a gastric ulcer or a duodenal ulcer. Either it can be a gastric ulcer or a duodenal ulcer. Please remember, if it is gastric ulcer, please remember, if it is a gastric ulcer, the pain would most likely start after eating the food. Okay, immediately after eating the food, the pain would be starting. Whereas in cases of duodenal ulcer, the pain would usually start 2 hours post meals. Okay, the pain. Just let me know if the voice is clear or is it still breaking. Occur after 2 hours of the meals. Okay, pain would usually occur after 2 hours of the meals. Okay, in gastric ulcer, as the patient has pain on at intake of food, therefore the patient will avoid food, and that will cause weight loss in the patient. So if there is weight loss in the patient, it is more likely to be a gastric ulcer. In cases of duodenal ulcer, on taking food, the patient will have like relief of symptoms. Otherwise, on empty stomach, the patient will have more pain. So there is a hunger pain actually in this patient. So if there is hunger pain, the patient will keep on snacking something. Therefore, there would be a weight gain. So if there is a weight gain, it is usually a duodenal ulcer. Weight loss, gastric ulcer, weight gain, duodenal ulcer. Right? Important. Now, please let me know, guys, which is the most common source of bleeding. If they ask you, bleeding is the most common complication in cases of peptic ulcer disease. Okay, please remember, the most common complication in peptic ulcer disease is definitely bleeding, followed by perforation. Okay, bleeding is much more common, and the most common type of peptic ulcer is duodenal ulcer. The more common type of peptic ulcer is duodenal ulcer. Please let me know which is the most common source of bleeding in gastric ulcer and in duodenal ulcer. So here our case is having abdominal pain 2 hours post meals. So definitely we are thinking in terms of duodenal ulcer, and the most common source of bleeding is usually the gastroduodenal artery. Okay, the most common source of bleeding is the gastroduodenal artery. Very good, guys. It is the gastroduodenal artery. This is important question, one liner. The most common source of bleeding in peptic ulcer, gastroduodenal artery. Most common source of bleeding in duodenal ulcer, gastroduodenal artery. But most common source of bleeding in gastric ulcer, then your answer should be left gastric artery. Most common source of bleeding in gastric ulcer, the answer would be left gastric artery. Then perforation is common at which part of the stomach? In gastric ulcer, perforation would be common on which part of the stomach? Perforation are common at which part of the stomach in gastric ulcer? It is your lesser curvature. Please remember, it is your lesser sac. Okay, so perforation in gastric ulcer are more commonly occurring at the lesser sac. Perforation in gastric ulcer are more commonly occurring at the lesser sac. Whereas in cases of duodenal ulcer, perforations more commonly occur on the anterior wall. In duodenal ulcer, perforations more commonly occur on the anterior wall. Right? Now, what is the most common site of gastric ulcer? Most common site of gastric ulcer. Jaldi batao. Most common site of gastric ulcer would be? Most common site of gastric ulcer would be lesser curvature. Most common site of gastric ulcer is usually lesser curvature. Most common site of gastric ulcer is lesser curvature. Whereas most common site of duodenal ulcer would be? Most common site of duodenal ulcer would be anybody? Most common site of duodenal, is it the first part of duodenum or the second part of duodenum? Most common site of duodenal ulcer, it is D1. That is your first part of your duodenum or your duodenal cap. Okay, it is D1. That is your first part of your duodenum. Now, if I talk about perforation, as I told you, perforation is common in lesser sac in gastric ulcer and on anterior wall of duodenum in duodenal ulcer. So after there is perforation of a peptic ulcer, there would be accumulation of gas under the diaphragm. And on X-ray, you can see something, this kind of a picture where there is a gas under diaphragm. So gas under diaphragm is also known as with sign. This is called as with sign. So where there would be air in the peritoneum, this is called as pneumoperitoneum, right? This condition would be called as pneumoperitoneum, right? This is called as pneumoperitoneum. What is the sign known as? Gas under diaphragm is also known as with sign. Gas under diaphragm is also known as with sign, guys. Gas under diaphragm is known as with sign. Jaldi, itna time kaise? Gas under diaphragm is known as the cupula sign. Gas under diaphragm is known as the cupula sign. Okay, gas under diaphragm is known as the cupula sign. Also known as the meniscus sign. It is also called as the meniscus sign. Okay, half moon shaped, and therefore it is also called as the meniscus sign, or it can also be called as the moustache sign. It can also be called as the moustache sign. Anybody, jaldi se batao bhi. Reverse moustache sign is a feature of. Reverse moustache sign is a feature of. Reverse moustache or antler sign is a feature of. Here it is the cupola sign, meniscus sign, moustache sign, or a reverse antler sign. But antler sign, very good. Antler sign or reverse moustache sign. Antler sign or reverse moustache sign is usually a feature of CHF, congestive heart failure. That is more commonly a feature of CHF, congestive heart failure. So pneumoperitoneum में तो cupola sign दिखती है. Please let me know which is the sign seen in pneumomediastinum when there is rupture of the esophagus, as in cases of a chronic alcoholic having a lot of binge drinking and now having recurrent vomiting or retching episodes, and therefore the esophagus has ruptured. Okay, complete esophagus rupture that causes pneumomediastinum. What is the sign of pneumomediastinum on a chest X-ray? Sign of pneumomediastinum on a chest X-ray is known as continuous diaphragm sign. Yeah, definitely the case is Bohr-Haave syndrome. Okay, the case is Bohr-Haave syndrome, but the sign is known as continuous diaphragm sign. The sign is known as continuous diaphragm sign. I can see the air shadow beneath the heart also. That is called as the continuous diaphragm sign of pneumomediastinum. Okay, no issues with this. I hope I have explained you. Yeah, very good. On auscultation, please remember, on chest X-ray, continuous diaphragm sign is seen, and on auscultation in Bohr-Haave syndrome, there would be a Hammond-Crunch sign. On auscultation in Bohr-Haave syndrome, which sign would be there? Hammond-Crunch sign. On auscultation in Bohr-Haave syndrome, there would be a Hammond-Crunch sign. Or if it appears like someone is walking with leather boots on a snow. So leather boots on a snow sound, or maybe a Hammond-Crunch sign on auscultation in Bohr-Haave syndrome. No issues with this? I hope so. And which is the triad in Bohr-Haave syndrome? Jaldi batao. Which is the triad in Bohr-Haave syndrome? Sorry. Which is the triad in Bohr-Haave syndrome? Very good. It is known as the macular triad, and the triad in Bohr-Haave syndrome is known as the macular triad. Three features of macular triad: due to there would be rupture of esophagus, therefore the patient will have chest pain. The first feature of macular triad is chest pain. Second feature of macular triad, there would be vomiting. Second feature of macular triad, there would be vomiting. And third feature, there would be a subcutaneous emphysema. Third feature is a subcutaneous emphysema in the patient. Okay, so subcutaneous emphysema, or on palpation there would be a crepitus. On palpation there would be a crepitus in the chest. Okay, so all of these features you need to remember. Okay, please remember this. No issues with this. Bohr-Haave syndrome. Bohr-Haave syndrome में investigation of choices. jaldi se. Bohr-Haave syndrome में the investigation of choices. In Bohr-Haave syndrome, the investigation of choices. Anybody? The investigation of choice for Bohr-Haave syndrome is, first line would be a chest X-ray on which we can see a continuous diaphragm sign. But the investigation of choice for Bohr-Haave syndrome is usually CECT chest. Very good. A CECT chest, that is a contrast enhanced CT chest, and a water soluble contrast like gastrographin can be given. So investigation of choice for a Bohr-Haave syndrome is CECT chest, and treatment would be immediate surgical repair. Treatment would be immediate surgical repair in the patient. No issues with this? Along with mediastinal lavage, cleaning of mediastinum should also be done. Now, peptic ulcer, more common as we discussed, is the duodenal ulcer. And one cause of duodenal ulcer can also be a H. pylori, that is Helicobacter pylori organism. And this H. pylori or Helicobacter pylori, as we know, it is a gram-negative bacteria. Okay, it is a gram-negative coccobacilli. H. pylori or Helicobacter pylori is a gram-negative coccobacilli, which is a known cause of chronic gastritis type B. It is a known cause of chronic gastritis type B, or it is also a known cause of peptic ulcer disease. It is also a known cause of peptic ulcer disease in the patient, right? So if there is chronic gastritis type B in the patient, or if there is H. pylori peptic ulcer disease, what should be the treatment of choice? Anybody? The treatment of choice for H. pylori ulcer or H. pylori gastritis would be H. pylori ulcer or H. pylori gastritis. So drug of choice for PPI, drug of choice for peptic ulcer disease, I've asked you, definitely those are PPIs, proton pump inhibitors. Drug of choice for peptic ulcer disease are definitely PPIs, proton pump inhibitors. Drugs like prazoles, that is omeprazole, lansoprazole, rabeprazole, all of these. Okay, so definitely proton pump inhibitors are the drug of choice for any of the peptic ulcer disease for any reason. But for H. pylori, definitely the eradication therapy would be the best. Okay, either it is your triple therapy or your quadruple therapy. Triple or your quadruple therapy. So in triple therapy, please remember we can give cap. Okay, in triple therapy, we give cap to the patient. That means C goes for clarithromycin, antibiotic. C goes for clarithromycin. A goes for amoxicillin. A goes for amoxicillin. And P goes for PPI. So 2 antibiotics along with the PPI is given. So what is the triple therapy? Cap. C for clarithromycin, A for amoxicillin, and P for proton pump inhibitor in the patient like trazodone drugs. Okay. Whereas quadruple therapy mein what should be there? So please remember in quadruple therapy, there should be again 2 antibiotics. It can be either clarithromycin, amoxicillin, tetracycline, or metronidazole. Any of these can be there. Along with that, definitely a PPI should be there. Along with that, we will give a mucosa protective agent. And the mucosa protective agent given in quadruple therapy is known as anybody. The mucosa protective agent given in quadruple therapy is known as Jaldi say. Mucosa protective agent given in quadruple therapy is known as bismuth subcitrate. It is known as bismuth subcitrate. It is known as bismuth subcitrate. Okay, it will cover the mucosa. Okay, so please remember it is a mucosa covering agent. No issues with this. So quadruple therapy. What is the investigation of choice for Helicobacter pylori? What is the investigation of choice for Helicobacter pylori? Anybody? Investigation of choice for Helicobacter pylori. Investigation of choice for Helicobacter pylori. Breath urea test is the screening test for Helicobacter pylori. Okay, breath urea test is the screening test for Helicobacter pylori. I'm again repeating, breath urea test or urea breath test is the screening test for Helicobacter pylori. The best test would be, or the investigation of choice would be a urease test. Okay, it is the urease test. So urease test on a biopsy is the best test for Helicobacter pylori. Okay, urease test on a biopsy is the best test for Helicobacter pylori. Okay, urease test on a biopsy is the best test for Helicobacter pylori. And the toxins that are produced by Helicobacter pylori are usually the VAC-A or the CAG-A toxins. The toxins produced by Helicobacter pylori are CAG-A or the VAC-A toxins. And the enzyme which is present in Helicobacter pylori, as we know, it is the urease enzyme, which will break down the urea into ammonia. It is known as the urease enzyme. So screening test, urea breath test, but investigation of choice, urease test on biopsy. What is the investigation of choice for peptic ulcer? Anybody? Investigation of choice for peptic ulcer. Investigation of choice for peptic ulcer. Let me know. Investigation of choice for peptic ulcer disease. Very good. Upper GI endoscopy plus biopsy. Investigation of choice for peptic ulcer is upper GI endoscopy plus biopsy. Upper GI endoscopy is definitely done. Sometimes you also perform a biopsy along with it. Why? Just to confirm that it is not a malignancy or something, right? So definitely investigation of choice is the upper GI endoscopy along with biopsy would be the best option. Okay, along with biopsy would be the best option to be answered. No issues with this. Drug of choice for peptic ulcer disease is definitely PPIs. Trazodone drugs for almost a period of 6 weeks you need to give them. I hope I have covered everything over here. Okay, please remember H. pylori can cause chronic gastritis type B. B for bacteria. Type A chronic gastritis is caused by autoimmune condition. When there are autoantibodies against the, I'll discuss it further. Okay, type A gastritis. Please remember, type A gastritis is the autoimmune gastritis. Okay, and type A gastritis, here autoantibodies are formed. These will damage which cells? So the antibodies will damage the parietal cells of the stomach. Okay, the antibodies will damage the parietal cells of the stomach, and therefore there would be decreased amount of HCl produced, and this is known as hypochlorhydria or achlorhydria. This is known as hypochlorhydria or achlorhydria. Along with this, there would be deficiency of intrinsic factor of Castle. There would be deficiency of intrinsic factor of Castle. If intrinsic factor of Castle is deficient, there would be deficiency of which vitamin? Which vitamin would not be absorbed? There would be deficiency of vitamin B12. Very good. There would be deficiency of vitamin B12, and which leads to pernicious anemia in the patient. Which leads to pernicious anemia in the patient. Along with that, if there is decreased HCl, so for stimulating HCl secretion, which is the hormone which would be elevated, so there would be increased levels of which hormone? Anybody? Physiologist a question. Which is the hormone which increases HCl secretion, which will stimulate the parietal cells? Which levels are elevated in autoimmune gastritis? Very good. It is gastrin. So there would be hypergastrinemia in the patient. There would be hypergastrinemia in the patient. Okay? No issues with this. So there would be anti-parietal cell antibodies in the patient or anti-intrinsic factor Castle antibodies in the patient. Okay? No issues. So autoimmune gastritis, therefore it can be treated with steroids. Okay? It can be treated with steroids in the patient. No issues with this. I hope so. Now please let me know which is the type of tumor which is associated with Helicobacter pylori. Which are the types of tumor associated with Helicobacter pylori? We know the tumors which are associated with Epstein-Barr virus. We have discussed about them. Okay, the tumors associated with Epstein-Barr virus, we know it is the non-Hodgkin's lymphoma, Burkitt's lymphoma, vagara. It is your Hodgkin's lymphoma, right? It is your Hodgkin's lymphoma. It is your nasopharyngeal carcinoma. It is your nasopharyngeal carcinoma in the patient. So non-Hodgkin's lymphoma, Hodgkin's lymphoma, nasopharyngeal carcinoma, all of these are definitely associated with Epstein-Barr virus. Okay. Please let me know which is the type of carcinoma associated with Helicobacter pylori. Very good. If they ask you carcinoma, then the tumor associated with H. pylori, the carcinoma associated with H. pylori is definitely gastric adenocarcinoma. Okay, the carcinoma associated with H. pylori is definitely gastric adenocarcinoma. And it can also cause a lymphoma. Anybody, which type of non-Hodgkin's lymphoma is caused by H. pylori? Which type of non-Hodgkin's lymphoma is caused by H. pylori? Which type of non-Hodgkin's lymphoma is caused by H. pylori? Jaldi say. Which type of non-Hodgkin's lymphoma is caused by H. pylori? Helicobacter pylori causes which type of lymphoma in the patient? It causes a myeloma. It causes a myeloma. Please remember, yes, it is a mantle cell lymphoma, so it causes a myeloma. Mucosa-associated lymphoid tissue tumor or mucosa-associated lymphoid tissue lymphoma. That is known as myeloma caused by Helicobacter pylori. So important two things you need to remember, right? Important. Okay, no issues with this. I hope so. Moving further, guys. Now talking about this question. Here you can see a 40-year-old patient presents with epigastric pain. There is heartburn and diarrhea also. Okay, so epigastric pain, heartburn are definitely features of peptic ulcer disease also. They are also seen in cases of gastritis. It is also a feature of GERD, that is gastroesophageal reflux disease, right? But here the patient is also having diarrhea. Upper GI endoscopy shows multiple duodenal ulcers. So if the patient is having recurrent or multiple duodenal ulcers, what is the most likely provisional diagnosis? The more likely provisional diagnosis, having a patient having recurrent and multiple duodenal ulcers, the most likely diagnosis is Zollinger-Ellison syndrome. The most likely diagnosis is Zollinger-Ellison syndrome. And in Zollinger-Ellison syndrome, there would be tumor of which cells? There would be tumor of the cell secreting gastrin. There would be tumors of the cell secreting gastrin. G cells ka tumor hota hai, and therefore it is called as a gastrinoma. Therefore it is called as a gastrinoma. Which is the most common site of gastrinoma? Anybody? The most common site of gastrinoma would be which triangle? The most common site of gastrinoma is which triangle? The most common site of gastrinoma is which triangle? So please remember, the most common type of gastrinoma is known as the gastrinoma triangle or the Passaro triangle. Most common site of gastrinoma is known as the gastrinoma triangle or the Passaro triangle. And out of the Passaro triangle, so here this is the Passaro triangle in which usually gastrinomas are more common. It can either be in the pancreas, it can be in the stomach, or it can be in the duodenum as well. Okay, so the most common site is usually the duodenum. But which part of duodenum? So the second part of duodenum, D2. Peptic ulcer disease are common in first part of duodenum. Please remember, peptic ulcers are common in first part of the duodenum. But recurrent ulcers due to gastrinomas are more common in the second part of the duodenum. They are more common in the second part of the duodenum. Okay, no issues with this. I hope so. There would be elevated levels of gastrin, definitely, as it is a gastrin producing tumor. Okay, can anybody tell me Zollinger-Ellison syndrome is associated with which men syndrome? Zollinger-Ellison syndrome is associated with which men syndrome? Multiple endocrine neoplasia. Men 1, men 2A, or men 2B. Zollinger-Ellison syndrome can be associated with, it can be associated with men 1 syndrome, or it can be associated with men 2A. Okay, so please remember, Zollinger-Ellison syndrome is commonly associated with men 1 syndrome, sometimes with men 2A also. Okay, so in men 1 syndrome, I hope all of you are quite aware, there are 3 P's you need to remember. The most common tumor in men 1 syndrome is parathyroid adenoma. Most common tumor in men 1 syndrome is parathyroid adenoma. Okay, whereas there can be pancreatic adenomas as well. And these pancreatic adenomas are nothing else but the gastrinomas. The pancreatic adenomas which are formed are nothing else but pancreatic adenomas. Okay, and the last one, the third P you need to remember is the pituitary adenoma, like prolactinoma. Most common type of pituitary adenoma is prolactinoma. Pheochromocytoma, please remember, pheochromocytoma are seen in men 2A and not in men 1. Pheochromocytoma are seen in men 2A and not in men 1 syndrome. Men 1 syndrome is also called as the Wermer syndrome. Men 1 syndrome is also called as the Wermer syndrome, whereas men 2A is also called as the Sippel syndrome. Men 2A is also called as the Sippel syndrome. Men 1 is due to mutation in which gene? MEN1 is due to mutation in the MEN1 gene. MEN1 syndrome is due to mutation in the MEN1 gene. And MEN1 gene is located on chromosome number. MEN1 gene is located on chromosome number. Jaldi se. MEN1 gene is located on chromosome number. MEN1 gene is located on chromosome number. Chromosome number 11, 1 for 1. Okay, so MEN1 gene is located on chromosome number 11, whereas MEN2A and MEN2B are usually due to red proto-oncogene mutation. Okay, MEN2A and MEN2B are usually due to red proto-oncogene mutation, and it is located on chromosome number 10. It is located on chromosome number 10. Okay, no issues with this. I hope so. I've made myself clear. Okay, yaad rakhna please. This is important, guys. What is the investigation of choice, as they have asked you? So definitely, if I talk about screening test would be increased gastrin levels. Okay, increased serum gastrin levels would be the screening test of choice in the patient. For localization of tumor, definitely we can perform investigations. Imaging modalities like MRI can be done. Okay, for investigation, definitely we can perform an endoscopic ultrasound. Okay, endoscopic ultrasound can be done. Endoscopic ultrasound can be done, or even an MRI can be done for localization of the tumor. But the investigation of choice would be very good. It is the secreting study. Very good, Arun. It is the secreting study. Okay, so please remember the investigation of choice is secreting study. Investigation of choice is secreting study in the patient. No issues with this. And what is the treatment of choice? Definitely, again, the drug of choice would be PPIs in this patient. Again, the drug of choice would be PPIs in this patient. Okay, I hope so. I've answered all of your queries now. Moving further to some esophageal conditions. Here you can see a esophageal condition where there is constant spasm of the lower esophageal sphincter. The normal lower esophageal sphincter pressure is between less than 25 mm/Hg. The normal lower esophageal sphincter pressure of esophagus is less than 25 mm/Hg. But here the pressure exceeds more than 25 mm/Hg in the lower esophageal sphincter, and therefore this sphincter is in constant spasm. Therefore, this sphincter is in constant spasm, and therefore the patient will have progressive dysphagia. Therefore, this patient will have progressive dysphagia. The patient has progressive dysphagia, and this dysphagia is more for liquids or solids. Anybody? This kind of dysphagia is more for liquids or solids? Very good. This very good. It is more for liquids because they are lighter. Okay, so this kind of dysphagia is more for liquids as compared to solids. So definitely, if I perform a barium swallow, it is the first line investigation, a barium swallow. On that, I can see these narrowing of the distal esophagus, and that is called as the bird beak appearance. This is called as the bird beak appearance or the pencil tip appearance. It is called as the bird beak appearance or the pencil tip appearance. Never call it as rat tail appearance. Rat tail appearance means there would be a shaggy borders. Okay, so shaggy borders usually in a narrow esophagus, they are a feature of rat tail appearance, and rat tail appearance is seen in anybody. Rat tail appearance is seen in carcinoma esophagus. Very good. Rat tail appearance is seen in carcinoma esophagus. Okay, important. So talking about this condition, this is known as achalasia cardia. Definitely this condition is known as achalasia cardia when there is constant spasm of the lower esophageal sphincter of esophagus causing progressive dysphagia, halitosis, regurgitation in a patient, and there would be a proximal dilated part and a narrowed distal part, okay, giving a bird beak or a pencil tip appearance on the barium swallow. What is the investigation of choice, Jaldi? Investigation of choice. pH monitoring क्यों करोगे तुम? pH monitoring, ambulatory pH monitoring for 24 hours is the investigation of choice for GERD, gastroesophageal reflux disease. Investigation of choice for GERD is 24-hour ambulatory pH monitoring when the pH goes less than 4 for 4 times a day. So here definitely you need to check for the pressure. So it is esophageal manometry. Investigation of choice is esophageal manometry, on which you can see a pressure more than 25 mm of Hg. Pressure more than 25 mm of Hg in a patient. Again, if you perform esophageal manometry in a patient in this condition, so you performed a barium swallow and you got this type of appearance. This kind of appearance came in December 2021. What is this kind of appearance called as? This is known as your which appearance? This is known as your corkscrew appearance. This is known as your corkscrew appearance or the rosary bead appearance. This is known as your corkscrew appearance or the rosary bead appearance. And it is a feature of diffuse esophageal spasm. This is a feature of diffuse esophageal spasm when the esophageal pressure would be more than 120 mm of Hg. When the esophageal pressure is more than 120 mm of Hg. Okay, such a high pressure will cause a corkscrew appearance or rosary bead appearance on barium swallow seen in diffuse esophageal spasm in a patient. When the pressure is more than 180 mm of Hg, it is called as which esophagus? Anybody? Pressure more than 180 mm of edge, it is called as which esophagus? Very good. It is known as the nutcracker esophagus. It is called as the nutcracker esophagus. When pressure is more than 180 mm of edge, it is called as the nutcracker esophagus. Very good, guys. Important. No issues with this. What is the treatment of choice for achalasia cardia? Treatment of choice for achalasia cardia is? Treatment of choice for achalasia cardia is? We can perform a Heller's cardiomyotomy. Okay, we can perform a Heller's cardiomyotomy. The treatment of choice for my achalasia cardia is Heller's cardiomyotomy. Laparoscopic Heller's cardiomyotomy is performed. Along with that, we can also do a Nissen's fundoplication. We can even do a Nissen's fundoplication in the patient. But Nissen's fundoplication is more likely done in cases of GERD. Okay, Nissen's fundoplication is more likely done in cases of GERD, gastroesophageal reflux disease. Yes, here we can better do a partial fundoplication. Okay, DORS bolte usko. No issues with this. I hope I'm done with achalasia cardia. Apart from that, from medicine point of view, you can also use some calcium channel blockers or botulinum toxin also in this patient, or even nitrates can be used to relieve the pressure. Okay. Then over here, if I can see on an endoscopy of the esophagus, I can see such concentric rings. Okay, concentric rings or concentric or repeated constrictions are seen in the esophagus. This is called as which esophagus? Anybody? And if I take a biopsy of this esophagus, I will find more than 15 eosinophils per high power field of microscope. On biopsy, I will find more than 15 eosinophils per high power field of microscope and repeated constrictions in the esophagus. No, it is not curling. It is known as the feline esophagus. This is known as the feline esophagus, also known as eosinophilic esophagitis, also known as eosinophilic esophagitis. So please remember, eosinophilic esophagitis is when there is infiltration of eosinophils in the esophagus and it causes repeated constrictions of the esophagus, known as feline esophagus. Feline means cat-like esophagus. Cat ki esophagus aisi hoti hai. Okay, no issues with this. Now, next, Curling's ulcer. Please remember, Curling's ulcer are usually seen in burns in the stomach. Cushing's ulcers are seen in the stomach due to raised ICP. Okay, no issues with this. Next, elderly patient coming to you with 3 characteristic features. There is a non-progressive dysphagia in the patient. Okay, elderly patient coming to you with non-progressive dysphagia. There is halitosis or bad breath in the patient, and there is regurgitation of previous day food items in the patient. Regurgitation of previous day food items in the patient. This is the triad for. This is the classical triad in an elderly patient on barium swallow, which is the investigation of choice. Investigation of choice is a barium swallow. On that, you can see a pouch which is coming out from the esophagus. And this is actually a Zenker's diverticulum. Which is the most common site of Zenker's diverticulum, anybody? The most common site of Zenker's diverticulum. Most common site of Zenker's diverticulum is? The most common site for Zenker's diverticulum is? Very good. It is the Killian's dehiscence. Okay, most common site of Zenker's diverticulum is the Killian's dehiscence. And Killian's dehiscence is seen in which muscle? Killian's dehiscence is seen in which muscle? It is seen in the inferior constrictor muscle. It is seen in the inferior constrictor muscle. Between which fibers? Very good. So all of these are questions about Zenker's. So it is seen between the oblique fibers of the thyropharyngeus. It is seen between the oblique fibers of the thyropharyngeus and the circular fibers of the cricopharyngeus. Oblique fibers of thyropharyngeus and circular fibers of cricopharyngeus. So this triangle, it is actually known as the Killian's dehiscence, which is the most common site for Zenker's diverticulum. Zenker's diverticulum, thumb sign you can see on barium swallow, but remember thumb sign on neck x-ray, acute epiglottitis in children, thumb sign on barium swallow, it would be Zenker's diverticulum. Okay, issue yaad rakhna. And the treatment of choice is definitely surgical. Dohleman's operation and all of that can be done in this patient. Okay, no issues with this. So please remember, diverticulopexy or Dohleman's operation is the treatment of choice in cases of Zenker's diverticulum. No issues with this. Anybody? Moving further. Moving further, if I see such a white patch in the oral cavity or on the tongue in a patient, okay, so it is called as, this white patch cannot be scraped out, okay, the white patch cannot be scraped out, and this is seen in the oral cavity of patient. What is this called as? White patch. Patch is plakia, white is leuco, so it is known as the leucoplakia. It is known as leucoplakia. It is known as leucoplakia. Whereas a red patch in the oral cavity or on the tongue, red patch on the oral cavity or on the tongue, it is known as, red means erythro, so it is known as erythroplakia. It is known as erythroplakia. Whereas over here you can see a curdy or a cottage cheese like patch, a curdy patch on the tongue or in the oral cavity. So this curdy patch in the oral cavity or on the tongue, it is suggestive of, curdy patch in the oral cavity or on the tongue is suggestive of Very good. It is suggestive of oral candidiasis. It is suggestive of oral candidiasis. It is also called as oral thrush. Okay, it is also called as oral thrush. A curdy or a white cottage cheese like patch is seen on the oral cavity or on the tongue. Okay, and oral candidiasis is more common in HIV positive or immunocompromised patient. Candidiasis is more common in HIV positive or immunocompromised patient. It can also be seen in asthmatic patient when they take inhaled corticosteroids for a longer time. Okay, when they take inhalers of corticosteroids for a longer time, that can also lead to oral candidiasis in an asthma patient. Treatment of choice is definitely fluconazole. Drug of choice is definitely fluconazole. Please let me know which are the pre-malignant lesions out of these. Which are the pre-malignant lesions out of these three? The pre-malignant lesions out of these three would be, very good. It is leukoplakia and erythroplakia. It would be leukoplakia as well as erythroplakia. Whereas the most pre-malignant lesion would be erythroplakia. Red means danger, na? So the most pre-malignant lesion would be erythroplakia. The most pre-malignant lesion would be erythroplakia. No issues with this? Important. Please remember this. Now, if I perform an endoscopy of stomach in a patient, upper GI endoscopy is done, and in stomach I can see these giant gastric rugae. So giant rugae are seen in the stomach. Okay, giant gastric rugae are seen in the stomach, and these give me a cerebriform appearance, brain-like appearance there, na? So these are giving me a cerebriform appearance. This is suggestive of which condition, anybody? So giant rugae on endoscopy giving a cerebriform appearance in the stomach is suggestive of, please remember, it is suggestive of which disease? This is suggestive of Menetrier disease. This is suggestive of Menetrier disease. Important one-liner. This is suggestive of Menetrier disease. And what is the histological or histopathological hallmark of Menetrier? What is the histopathological hallmark of Menetrier disease? Histopathological hallmark of Menetrier disease, anybody? Histopathological hallmark of Menetrier disease is hyperplasia of which cells or which epithelium? There would be a hyperplasia of foveolar epithelium. Hyperplasia of foveolar epithelium. Hyperplasia of foveolar epithelium in the stomach. Okay, please remember this. And there would be a protein losing and gastropathy in this patient. There would be loss of proteins due to excess mucus secretions. Okay? No issues with this. Please remember this. Next, if I talk about this condition, on upper GI endoscopy, I can find that there is some change in the normal lining of the esophagus. There is some change in the normal lining of the esophagus. Normal lining of esophagus is stratified squamous epithelium. Normal lining of esophagus is a stratified squamous epithelium. But if a patient is having GERD, that is gastroesophageal reflux disease, due to constant gastric reflux, due to constant acid reflux into the esophagus, in the lower one-third part of the esophagus, there would be change of the epithelium. From squamous epithelium, it will change to a columnar epithelium. From squamous epithelium, it will change to a columnar epithelium, and this is called as columnar metaplasia. Okay, this is called as columnar metaplasia. So here you can see there is change in the epithelial lining, and this columnar metaplasia which is seen, or the intestinal metaplasia which is seen, if I take a biopsy, such feature would be seen. Okay, so all of these would be the normal squamous lining, and here you can see there is glands which are formed. Okay, that means there is columnar lining which is being formed. Okay, so it is due to the cellular adaptation, metaplasia is being developed. So it is a columnar or intestinal metaplasia. Okay, and this condition is called as, anybody? Very good. This condition is called as the Barrett's esophagus. This condition is called as the Barrett's esophagus. Okay, and in Barrett's esophagus there would be intestinal metaplasia, but the hallmark feature of Barrett's esophagus is histopathological hallmark, or the biopsy feature of Barrett's esophagus is, anybody? Biopsy feature of, very good, that is goblet cells. The hallmark feature would be goblet cells which are secreting mucin. They are normally seen in the intestine, and therefore it is called as intestinal metaplasia. So intestinal metaplasia along with presence of goblet cells, it is a feature of Barrett's esophagus. It is a feature of Barrett's esophagus. Okay, please remember this. Don't forget this at any point. Which is the stain used for Barrett's esophagus? So if they ask you the most common complication of gastroesophageal reflux disease, please remember, answer it as esophagitis. Most common complication of gastroesophageal reflux disease is esophagitis and not Barrett's. Barrett's comes usually later in the course when there is metaplasia. Okay? Barrett's is usually a late complication, not the most common one. So most common is esophagitis. Late complication is Barrett's esophagus. And the stain used from Barrett's esophagus, very good, Gopi, it is Alcian blue stain. Which stain is used? We use the Alcian blue stain. We use the Alcian blue stain. Okay, please remember. And as we know, Barrett's esophagus is a pre-malignant condition. Barrett's esophagus is a pre-malignant condition. And which type of cancer would be seen in esophagus? Due to Barrett's esophagus, which type of cancer is seen in esophagus? It is usually a adenocarcinoma. It is usually a adenocarcinoma. Very good. So due to Barrett's esophagus, we can see a adenocarcinoma of esophagus. And what is the most common site for adenocarcinoma esophagus? Most common site for adenocarcinoma esophagus is? Most common site for adenocarcinoma esophagus is? So the most common, very good, it is the lower 1/3. It is the lower 1/3. So most common site for adenocarcinoma esophagus is usually the lower 1/3 because Barrett's occurs in the lower 1/3. Whereas the most common type of cancer in esophagus, most common type of cancer in esophagus is the squamous cell carcinoma. Most common type of cancer in esophagus is the squamous cell carcinoma, and which is most commonly in the middle 1/3. Which is most commonly in the middle 1/3. Okay, no issues with this. Okay, please remember these are the important one-liners that you need to remember. Next question says, guys, a patient presents with bloating. Okay, there is diarrhea. Bloating means there would be flatulence or the gas would be accumulated as such. Okay, in layman terms, there would be bloating, there would be diarrhea, there would be steatorrhea. Steatorrhea means greasy, fat-forming, bulky stools. Okay, foul-smelling, greasy, fat-forming, bulky stools. It is usually a feature of fat malabsorption. It is usually a feature of fat malabsorption in a patient. And there is also dementia in the patient. Small intestinal biopsy was performed as there was malabsorption syndrome. So the small intestinal biopsy shows past positive macrophages in the lamina propria. So this is the mucosal layer, and in the mucosal layer of lamina, and in the mucosa or the lamina propria, you can see these past positive macrophages. You can see this past positive macrophages in the patient. Okay? So past positive macrophages in, guys, I knew this, you would answer that. Please remember, in celiac screw, guys, the other symptoms would be fine. Bloating, diarrhea, steatorrhea. Okay, all of these are fine, definitely. There would be iron deficiency, anemia as well because duodenum is affected. But would there be dementia? Dementia is not a feature of celiac screw, first thing. Secondly, small intestinal biopsy is also performed in celiac screw as the investigation of choice. But past positive macrophages are not seen in celiac screw. In celiac screw, such kind of a picture is seen where there is loss of cilia. Okay, there would be a loss of cilia or flattening of villi. Okay, so loss of villi or flattening of villi is a feature of celiac screw biopsy. Loss of villi or flattening of villi is a feature of celiac screw biopsy in a patient. Whereas here I am talking about past positive macrophages, and these past positive macrophages are due to presence of some intracellular bacteria. Okay, it is due to presence of the intracellular bacteria which is called as Trophirema vipelli. This is called as Trophirema vipelli, the intracellular bacteria which is past positive. And this condition therefore is known as Whipple's disease. This condition is a malabsorption syndrome known as Whipple's disease. Please remember, this is important. This is a bacterial infection causing malabsorption known as Whipple's disease due to intracellular bacteria known as Trophirema vipelli. And the investigation of choice is small intestinal biopsy. And the most histopathological important feature would be past positive macrophages in the lamina propria. All of these pinkish color appearance that you can see, these are past positive macrophages due to presence of the bacteria. No issues with this now. And what is the treatment of choice? Whipple's disease. Here, please remember, in Whipple's disease, there would be extra intestinal manifestations also. In Whipple's disease, there are also extra intestinal manifestation. And the most common extra intestinal manifestation would be arthritis or dementia. Most common extra intestinal manifestation would be something like arthritis or dementia in the patient. Okay? So, बाकी के symptoms अगर mentioned हो, think in terms of Whipple's disease. Definitely, as it is a bacterial infection, we will give antibiotics to the patient like third generation cephalic